Thousands of years before anesthesia, antibiotics, or sterile operating rooms, ancient surgeons were already cutting into human skulls, removing shattered limbs, restoring damaged faces, and operating on eyes with tools made of stone and bronze. Some patients died in agony, but others survived for years, leaving healed bones that still puzzle archaeologists today. How did these early healers perform procedures that seem impossible without modern medicine? Before we uncover their forgotten techniques, take a moment to like the video and subscribe to the channel for more mysteries from the ancient world. The skull lies beneath a thin layer of earth, its surface stained the color of old clay. Around it, the grave has collapsed inward over thousands of years, pressing soil into the hollow spaces where flesh once was. Nothing about the burial at first appears extraordinary. The body has been placed with the care common to many prehistoric communities, accompanied by a few worn tools, fragments of pottery, and traces of ochre. Yet when the skull is lifted into daylight, one detail changes the meaning of the grave. Near the crown is a clean opening, roughly circular, cut through living bone. The edges are not sharp. They have begun to round and smooth, showing new bone growth. Whoever endured this operation did not die immediately. The wound had time to heal. That single fact carries the story back beyond written medicine, beyond hospitals, anatomical textbooks, and formal schools of surgery. It reaches into a world where illness is explained through spirits, imbalance, injury, fate, or some mixture of all four, yet where human beings already possess the nerve to open the skull of another living person and the skill to keep that person alive. Before we go deeper, take a moment to like the video and subscribe. If this is the kind of history and mystery you enjoy, the story ahead is about observation gathered across generations, hands trained by repetition, and the unsettling realization that some of the most dangerous medical procedures begin when almost nothing is written down. Openings cut into skulls appear in archaeological sites across the world. They are found in Neolithic Europe, parts of Africa, ancient Asia, and the Americas. The operation is usually called trepanation, though the term covers several techniques. Some skulls were scraped gradually with stone tools until the bone thinned and gave way. Others were cut with repeated grooves, drilled with small perforations, or opened by removing a shaped piece of bone. The instruments could be simple, but the work was not. Human skull bone is hard, curved, and variable in thickness. Beneath it lies tissue that can bleed, swell, and become infected. A careless movement can tear protective membranes or damage the brain itself. In a prehistoric shelter lit by fire with no metal instruments, sterile field, or modern anesthesia, the risk seems almost impossible. Yet many patients survive. Archaeologists can often distinguish an opening made after death from one made during life because bone reacts to injury. If a person lives long enough, new tissue begins to form along the cut edge. In some skulls, the healing is extensive, suggesting survival for months or years. A few individuals appear to have undergone the procedure more than once. That does not prove every operation was successful. And the evidence remains incomplete because soft tissue rarely survives. It does show that trepanation was not merely a symbolic act performed on corpses. In many cases, it was surgery performed on the living. The reasons remain uncertain. Some patients may have suffered head injuries from falls, warfare, hunting accidents, or violence. A blow to the skull can cause depressed fractures, internal bleeding, and pressure within the head. Removing damaged bone may sometimes have relieved that pressure or cleared fragments from a wound. Other operations may have been intended to treat seizures, severe headaches, paralysis, unusual behavior, or conditions interpreted in spiritual terms. The boundary between medicine and ritual is difficult to draw in societies that do not separate body, mind, and supernatural belief as sharply as modern medicine does. A procedure can be practical and sacred at the same time. A healer might open the skull to relieve pressure while also believing that harmful forces must escape through the same opening. What survives in the record suggests that the people performing these operations learned through close attention. They knew that some areas of the skull were safer than others. They appear, at least in certain traditions, to have avoided major blood vessels and thick muscular attachments. They recognized when scraping was preferable to cutting. They may have understood that slow removal reduced the chance of piercing too deeply. None of this requires modern anatomical theory. It requires repeated experience, remembered outcomes, and knowledge passed from one practitioner to another. A community does not need words such as intracranial pressure or infection to notice that one technique kills quickly, while another sometimes allows recovery. The patient's ordeal can only be reconstructed indirectly. There may have been fermented drink, sedating plants, or pressure from assistants. The scalp had to be opened or pulled aside, bleeding had to be controlled, the bone had to be worked for a long time, especially when stone tools were used. Afterward, the wound needed protection from dirt, insects, and repeated injury. Plant fibers, animal materials, resins, fats, or herbal preparations may have been applied. Though such treatments rarely leave clear traces, scholars still debate how much prehistoric healers understood and how much success depended on luck, patient strength, and the naturally lower risk of certain techniques. The burial itself offers another clue. A person who survives a serious cranial operation does not recover alone. Food must be brought, the wound must be watched. Fever, weakness, confusion, or disability may follow. The healed skull therefore records more than surgical courage. It records care. Someone held the patient still. Someone cleaned blood from the head. Someone returned after the operation and continued to help. Surgery begins not only with the tool, but with a group willing to invest time and resources in an injured member whose survival is uncertain. This changes the familiar image of prehistoric medicine. It is easy to imagine ancient healing as little more than superstition, but the bone resists that simplification. Ritual may have surrounded the act. Explanations may have been wrong by modern standards. Still, the hands that cut the opening had learned something real about the body. They knew that bone could be removed without always causing death. They knew that wounds could close. They knew that a person altered by trauma or illness might sometimes return to life within the group. The skull in the grave cannot name the surgeon, it cannot describe the tools, the pain, or the beliefs spoken around the patient. It preserves only the result, an opening made deliberately, followed by survival. That narrow ring of healed bone is the first doorway into the history of surgery, a history that begins not in marble temples or royal courts, but beside a fire, with sharpened stone, steady hands, and a patient whose body carries the evidence that the impossible had already been attempted. The earliest known trepanations do not belong to one region, one people, or one medical tradition. They appear across vast distances and separated by thousands of years, as though different communities repeatedly arrive at the same unsettling idea that the skull can be opened and the patient may still live. In parts of Europe, some examples date back to the Neolithic period, when farming villages are beginning to spread and permanent settlements are changing the rhythms of life. In North Africa, the Eastern Mediterranean, Central Asia, and the Andes, other skulls preserve similar interventions. The techniques vary, the tools vary, and the reasons may vary. Yet the recurring pattern is difficult to dismiss. Human beings in societies with no known contact with one another learn to remove pieces of cranial bone deliberately. One of the most common methods is scraping. A practitioner uses a sharp stone edge and slowly grinds away the outer surface of the skull. The process is laborious, but it offers a degree of control. Instead of striking or cutting deeply, the operator reduces the thickness of the bone layer by layer. The outer table gives way first, followed by the porous middle section, until the inner layer becomes thin enough to open. This method may reduce the risk of suddenly plunging into the tissue below. It also produces characteristic sloping edges that archaeologists can identify thousands of years later. Another method involves grooving. The practitioner cuts repeatedly along a circular or rectangular path, gradually deepening the channel until a section of bone can be lifted away. Some skulls show 4 intersecting cuts forming an angular opening. Others carry rings of small drilled holes, later connected into a larger gap. Each method reflects a different understanding of tools, pressure, bone thickness, and time. The work may take many minutes or far longer. Depending on the instrument and the desired opening, the patient must remain nearly motionless while the head is held in place. The choice of location is rarely random. Openings often appear on the upper sides of the skull rather than directly over the face, jaw, or base. This may partly reflect practical access, but it may also indicate accumulated knowledge about danger. The region near the temples contains vulnerable blood vessels. The back of the head is covered by thick muscle, and lies close to important venous channels. The upper parietal area offers a relatively broad surface where bone can be reached more easily. Prehistoric healers do not need a formal map of the circulatory system to learn that cutting in one place causes uncontrollable bleeding, while cutting in another does not. Injury likely drives at least some operations. Prehistoric life produces frequent trauma. Hunting brings close contact with large animals and heavy weapons. Farming introduces falls, repetitive strain, and conflict over land or stored food. Clubs, sling stones, axes, and projectiles leave recognizable damage on skulls. Some trepanations are positioned near fractures, suggesting an attempt to remove splintered bone or treat the consequences of a blow. A depressed fracture can push bone inward, compressing tissue beneath it. If the victim remains conscious but deteriorates, a healer may associate the damaged area with the worsening condition. This does not mean that prehistoric surgeons understand the brain as modern medicine does. They may connect the injury with pain, vomiting, weakness, seizure, or altered behavior without knowing the internal mechanism. Observation alone can reveal that pressure and damaged bone matter. A person struck on the head may become confused, swelling may follow, removing fragments may occasionally lead to improvement. When that happens, the procedure becomes part of communal memory. Not every opening is associated with visible trauma. Some appear on otherwise undamaged skulls. These cases may reflect efforts to treat chronic headaches, epilepsy, mental disturbance, or symptoms understood as spiritual intrusion. In some societies, the opening itself may carry ritual meaning. Pieces of removed skull were sometimes preserved, shaped, or worn, perhaps as amulets or objects of status. Scholars still debate whether these fragments belong to survivors, honored ancestors, enemies, or sacred individuals. No single explanation fully accounts for every example. The most striking evidence comes from survival rates. At several archaeological sites, a large proportion of trepanned skulls show healing. In certain Andean populations, especially in later periods, survival appears remarkably high. The edges of the openings are rounded, remodeled, and partially closed by new bone. Some individuals live long enough for the original cut marks to soften almost completely. Others carry several openings made at different times, indicating repeated operations and repeated recovery. The Andean evidence is especially important because trepanation there becomes highly developed. Warfare in the region often involves clubs and sling stones, producing severe cranial injuries. Surgeons appear to refine their methods over centuries. Earlier operations are more variable and often less successful. Later examples show smaller openings, careful scraping, and better avoidance of dangerous areas. This gradual improvement resembles an experimental tradition. Though no written manual survived to explain it, outcomes may have been remembered, discussed, and passed down through apprenticeship. Stone tools are not necessarily crude in this setting. Obsidian can fracture into edges sharper than many modern steel blades. Flint and other fine-grained stones can also produce precise cutting surfaces. Sharpness alone does not make surgery safe, but it challenges the assumption that metal is required for delicate work. A fresh obsidian edge can slice skin cleanly, although it is brittle and must be handled with care. The true limitations lie elsewhere: controlling pain, preventing contamination, managing bleeding, and recognizing which patients can survive. Pain remains one of the darkest unknowns. Archaeology can reveal the opening but not the sensation. Alcoholic drinks, coca leaves, sedating herbs, or other plant preparations may have reduced distress in some regions. Pressure on the neck, compression of nerves, cold, or partial intoxication could have helped, though evidence varies. Assistance almost certainly restrained many patients. Speed may matter in some techniques, but scraping is slow by nature. The operation demands endurance from everyone involved. Infection is another danger, yet the skull's blood supply and the careful use of certain methods may have allowed more recovery than expected. Scraping produces less shattered bone than blunt cutting. Removing loose fragments can clean a traumatic wound. Honey, plant resins, alcohol, or antimicrobial herbs may sometimes have been applied, although direct proof is rare. Dry climates may also preserve bodies well while reducing certain environmental risks. But climate alone cannot explain successful healing. The evidence does not show a world in which trepanation is safe. Many patients certainly die, and some skulls preserve openings with no healing at all. It is often impossible to determine whether death comes during surgery, soon afterward, or from the original injury. The surviving remains are biased toward bone. While unsuccessful cases may be harder to recognize when damage is incomplete, even so, the repeated appearance of healed openings across continents confirms that the operation is more than desperate improvisation. Trepanation becomes one of humanity's earliest visible surgical traditions because bone remembers what flesh cannot. Skin decays, plant medicines vanish, and spoken instruction disappears, but the skull preserves the marks of technique. Every groove records the direction of a tool, every rounded edge records time survived, every repeated operation records confidence strong enough to attempt the procedure again. Long before medical writing, the human body itself becomes the archive, carrying evidence that ancient healers are already testing the boundary between injury and intervention, between fatal damage and deliberate repair. The knowledge behind those healed skulls does not appear suddenly. It grows in places where no medical school exists, where no written manual can preserve a successful method, and where nearly everything depends on memory. A healer watches a wound close, notices which plants ease swelling, remembers which fracture heals crookedly, and which one heals straight. Another person observes the same work, copies the hand movements, and learns which mistakes cannot be repeated, across generations. Treatment becomes a body of practical knowledge carried not on parchment, but in habits, gestures, stories, and apprenticeship. Before writing, medicine is not necessarily disorganized. It may be highly structured within a community, even if modern archaeology can recover only fragments of it. Knowledge can belong to a specialist, a family line, a ritual office, or a small group responsible for childbirth, injuries, fevers, and death. Some healers may also serve as spiritual authorities. Others may be valued primarily because they are good with their hands. The categories used today, surgeon, physician, herbalist. Priest may not exist separately. One person can set a broken limb, prepare a plant paste, interpret an omen, and perform a ritual over the same patient without seeing any contradiction. The body offers its own lessons. Bone can be felt beneath skin, joints bend in predictable directions, tendons tighten when fingers move, blood flows differently from a shallow cut than from a deep one, swelling, heat, colour, smell, and pain all provide information. A healer who treats many injuries begins to recognize patterns. A clean wound behaves differently from one filled with dirt. A straight fracture heals better when kept still. A dislocated joint may return to place with pressure and traction. A crushed limb may darken and become cold before the patient develops fever and dies. This is not scientific anatomy in the modern sense, but it is not ignorance either. It is anatomy learned from accident, hunting, animal butchery, childbirth, violence, and death. People who cut meat from carcasses understand the relationship between skin, fat, muscle, tendon, and bone. Hunters know where animals bleed most heavily and where a blade can pass between ribs. Those observations do not transfer perfectly to the human body, but they create a practical familiarity with flesh. In some cultures, preparation of the dead may provide additional knowledge, although the extent of deliberate human dissection before written medical traditions remains uncertain. Wound care is likely among the oldest forms of treatment. Cuts must be cleaned, covered, and protected from flies and dirt. Water may wash away visible contamination, though unsafe water can create new danger. Cloth, bark, leaves, animal skin, and plant fibers can serve as dressings. Pressure slows bleeding. A tight band around a limb may reduce blood loss, though excessive pressure damages tissue, ash, clay, fat, resin, honey. And crushed plants may be applied for reasons that combine symbolism with practical effect. Some of these substances can inhibit microbial growth or form protective barriers, even when the healer has no concept of bacteria. Fire also becomes a surgical tool. Heated stone or metal can cauterize tissue, sealing small vessels and destroying damaged flesh. The method is painful and dangerous, but in a world where uncontrolled bleeding can kill within minutes, pain may be the less immediate threat. Cauterization can also reduce some forms of contamination, though ancient practitioners do not know why. They know only that a burned wound sometimes stops bleeding and sometimes heals when an untreated one does not. Fracture treatment reveals the same pattern of observation. A broken arm or leg changes shape, swells, and becomes useless. If left unsupported, the bone may heal at a severe angle or fail to unite. Splints made from wood, reeds, bark, or layered cloth hold the limb still. Padding reduces pressure on skin. Bindings must be tight enough to stabilize the injury, but loose enough to preserve circulation. That balance is difficult even in modern care. Ancient healers likely learn it through failure as often as success. Archaeological skeletons sometimes preserve well-healed fractures, including injuries severe enough to prevent a person from walking or working for weeks. Healing does not prove that a formal surgeon set the bone, but the alignment of certain fractures suggests deliberate treatment. It also proves prolonged care. A hunter with a broken thigh cannot gather food alone. A farmer with a shattered arm cannot easily grind grain or carry water. Survival depends on others providing food, warmth, and protection, while the body repairs itself. The same is true for amputees. A few ancient skeletons show complete healing after the removal of a limb. Such cases are rare and often debated, because damage after death can imitate cutting. Where the evidence is convincing, however, the implications are profound. Removing a limb requires controlling blood loss, avoiding fatal shock, and managing the open wound. The patient then needs long-term support. One early individual from Borneo survives for years after the lower leg is deliberately removed. According to the interpretation of the remains, the case suggests not only technical skill, but detailed knowledge of local anatomy and sustained communal care. The evidence remains incomplete, yet the survival itself is difficult to explain as chance. Childbirth adds another field of accumulated expertise. Most births occur without surgical intervention, but complications are common and sometimes fatal. Experienced attendants learn fetal positions, patterns of labour, methods of massage, ways to support the mother, and signs that delivery is failing. They understand timing through experience rather than clocks. They know when bleeding is ordinary and when it becomes dangerous. Their knowledge is rarely preserved in early written records because it often passes through women's networks, family practice, and oral instruction. Much of the oldest medical history may therefore remain archaeologically invisible. Pain relief also emerges through experiment. Fermented drinks dull awareness. Certain plants cause sleepiness, numbness, confusion, or reduced pain. Others are toxic in slightly larger amounts. The difference between medicine and poison can be narrow, and dosage is difficult to control when plants vary by season, soil, and preparation. A healer may count leaves, measure by handfuls, or judge strength by taste and smell. Successful recipes survive because they are remembered. Fatal ones may also survive if the death is blamed on the illness rather than the treatment. No single explanation fully accounts for how effective methods spread. Marriage networks, seasonal gatherings, trade routes, warfare, and migration all allow techniques to travel. A healer may learn from a neighbouring group after witnessing an unfamiliar treatment. Captives may bring medical knowledge into a new community. Traders carry not only goods but stories about plants and remedies. Some practices remain local because they depend on plants found in one landscape. Others spread widely because the underlying problem, bleeding, fracture, infection, obstructed birth, is universal. What survives in the record suggests that early healing is built from a mixture of correct observation, mistaken explanation, practical success, and ritual meaning. A treatment can work for reasons the practitioner does not understand. Another can fail despite deep cultural confidence. The distinction between effective and ineffective medicine is often blurred because recovery itself is unpredictable. Many patients survive without intervention, others die despite skilled care. Without written records or controlled comparison, certainty is difficult. Still, the repeated survival of people with severe injuries shows that ancient communities possess more than hope. They develop techniques reliable enough to be taught, repeated, and trusted. The hand that scrapes a skull, aligns a fracture, closes a wound, or removes dead tissue belongs to a tradition already old before the first medical text is written. When writing finally appears in the great river civilizations, it does not create surgery from nothing. It captures only a portion of knowledge that has already been carried for generations in the memories of healers and in the scars of those who survived them. When writing finally begins to preserve medical knowledge, one of the clearest early records emerges beside the Nile, in a civilization where injury, ritual, craftsmanship, and administration are all observed with unusual care. Ancient Egypt does not produce surgery in the modern sense, and its healers do not abandon magic, prayer, or divine explanation. Yet within surviving papyri and archaeological remains appears a strikingly practical approach to wounds: fractures, tumours, burns, and bodily examination. The Egyptian healer often stands with one foot in the sacred world and the other in the workshop, studying what can be seen, touched, smelled, and tested. The Nile creates a society of builders, farmers, soldiers, boatmen, quarry workers, and craftsmen. Every one of these occupations produces injuries. Stone blocks crush hands and feet. Copper tools cut flesh. Falling timber breaks bones. Boats overturn. Animals gore or trample. Soldiers return with arrow wounds, shattered jaws, and blows to the head. Large building projects concentrate labour on a scale rarely seen before. And with that concentration comes a steady supply of trauma. A medical tradition that cannot treat wounds has little value in such a world. The document most often associated with Egyptian surgical practice is the Edwin Smith Papyrus, a surviving copy made around the 17th century BCE from material that may be older. Unlike many ancient medical writings, it is dominated not by spells but by case descriptions. The healer examines an injury, identifies symptoms, gives a diagnosis, offers a judgment about the likely outcome, and recommends treatment. The order is methodical. Look at the wound. Touch it. Ask the patient to move. Observe speech, posture, bleeding, swelling, and consciousness. Then decide whether the condition can be treated, fought against, or not treated at all. This final category is one of the most revealing. The text does not pretend every patient can be saved. Some injuries are described as conditions with which the physician should not contend. A crushed skull, exposed brain tissue, or damage causing paralysis may be recognized as beyond available skill. This restraint is significant. It suggests that Egyptian practitioners distinguish between intervention and futility, even if their understanding of internal anatomy remains limited. They do not possess modern imaging or neurological theory, but they observe that certain combinations of symptoms lead almost always to death. Head injuries receive especially careful attention. The papyrus describes wounds of the scalp, fractures of the skull, damage to the face, and injuries to the spine. It notes relationships between trauma and symptoms elsewhere in the body. A person with damage to the neck may lose control of limbs. A blow to the head may affect speech or movement. These observations do not form a complete theory of the nervous system, but they show close clinical attention. What survives in the record suggests that Egyptian healers recognize patterns that can only be learned by seeing many injured bodies. Treatment is often simple and practical. Wounds may be stitched, bound, covered with fresh meat during the first day, and later dressed with mixtures including honey and grease. The use of raw meat may have symbolic or cooling associations, and its medical value is doubtful. Honey, however, has properties that can inhibit some bacterial growth and help create a protective wound environment. The ancient healer does not know about microorganisms, but repeated experience may show that certain dressings produce cleaner wounds and less foul decay than others. Grease or animal fat can keep a dressing from adhering too tightly and may protect tissue from drying, though it can also trap contamination. Linen is widely available and becomes an important medical material. It can be folded into pads, wrapped around fractures, or used to hold dressings in place. Egypt's dry climate preserves some bandages remarkably well, revealing that textile skill extends beyond clothing and burial into practical care. The same culture that wraps the dead with precision also learns how to bind the living. Fractures are treated through splinting and immobilization. Wooden supports, padded linen, and firm bindings hold injured limbs in position. Some mummies and skeletons show healed fractures, though it is not always possible to determine whether healing followed skilled treatment or natural recovery. In certain cases, alignment suggests deliberate setting. Egyptian practitioners understand that movement worsens a break, and that stability gives the body time to repair itself. They do not know the cellular process of bone healing, but they know the outward pattern. Dislocations and facial injuries are also described. A displaced jaw can be manipulated back into place. Broken noses may be packed and supported. Wounds of the lips, cheeks, and brows can be stitched. These are small procedures compared with opening the abdomen or chest, but they require confidence, anatomical familiarity, and steady hands. The face bleeds heavily and swells quickly. A healer who repairs it must work through pain, fear, and the patient's movement. Egyptian medicine is often divided among specialists. Later writers claim that some physicians focus on particular parts of the body, such as the eyes, teeth, stomach, or head. These reports may exaggerate the degree of specialization, but surviving titles suggest that certain practitioners do develop narrower expertise. There are court physicians, temple healers, and individuals attached to workers' communities or royal households. Medical practice therefore exists within a hierarchy, shaped by status and access. A labourer injured at a worksite may receive practical care, while a member of the elite may have access to highly trained attendants and expensive preparations. Dentistry remains especially difficult. Egyptian diets include bread contaminated by fine stone particles from grinding, which gradually wear down teeth. Abscesses, infections, and severe dental pain are common. Archaeological remains show attempts to manage dental damage, but clear evidence for advanced dental surgery is limited. Some teeth may have been drained or removed, yet many individuals die with serious untreated disease. This is a reminder that even a sophisticated medical culture cannot solve every common problem. Tumours appear in Egyptian medical texts as swellings that can be examined by touch. Some are treated with cautery or topical applications. Others are recognized as untreatable. One famous passage describes a hard mass in the breast and concludes that there is no treatment. Whether this represents cancer in the modern sense cannot always be proven, but the description is chillingly recognizable. The healer can identify the danger without being able to stop it. Surgery in Egypt also remains entangled with ritual. Incantations may accompany treatment. Protective amulets may be worn. Illness can be attributed to divine forces, hostile beings, or imbalance. Modern readers sometimes treat these beliefs as evidence that Egyptian medicine is irrational, but the division is too simple. A healer may stitch a wound correctly and then recite a spell over it. The practical action and the sacred action serve different purposes within the same worldview. One addresses the flesh, the other addresses fear, fate, and the invisible cause believed to surround the injury. There are limits to what Egyptian surgeons attempt. Despite their experience with mummification, embalmers do not necessarily become physicians. A knowledge gained from preparing corpses may remain separate from the treatment of the living. Large internal operations are rare or undocumented. Opening the abdomen or chest would almost certainly cause fatal bleeding and infection. Amputation is possible in principle, but convincing evidence is uncommon. The most successful procedures remain those that can be performed on the body's surface, closing wounds, stabilizing bones, draining abscesses, removing foreign objects, and treating visible trauma. What makes Egyptian surgery remarkable is not that it resembles a modern operating room. It does not. Its importance lies in the disciplined habit of observation. The body is examined case by case. Symptoms are compared, outcomes are judged. Some injuries are treated aggressively, others cautiously, and some not at all. Along the Nile, surgery begins to leave a written shadow of itself, revealing a medical tradition that is still surrounded by gods, yet already learning to trust what the wounded body shows. East of the Nile, between the Tigris and Euphrates, surgery enters a harsher kind of record. Mesopotamian cities preserve not only medical recipes and ritual texts, but laws describing what happens when a healer succeeds, fails, or leaves a patient permanently damaged. Here the surgeon is not simply a mysterious specialist working at the edge of life and death. He is also a paid professional whose hands can earn silver, status, or punishment. The same knife that opens an abscess or repairs an injury can place its owner under the judgment of the state. Mesopotamian medicine develops within crowded cities where disease and trauma are common. Farmers are injured by plows, carts, and animals. Builders fall from walls and scaffolds. Soldiers suffer spear wounds, fractures, and crushed limbs. Craftsmen work beside furnaces, blades, and heavy stone. Merchants travel roads where robbery and accident are constant threats. The city concentrates people, animals, waste, smoke, and contaminated water in ways that create new medical pressures. Healers respond with a mixture of herbal treatment, manual intervention, ritual diagnosis, and careful observation. Two broad kinds of medical practitioner appear in the surviving record, though their roles may overlap. One relies heavily on incantation, divination, and the interpretation of supernatural causes. Another works more directly with remedies, bandages, examination, and physical treatment. Modern readers often try to separate them into magician and physician, but Mesopotamian patients may not have recognized such a sharp division. A wound can be cleaned and bound while a ritual is performed against the hostile force believed to have caused it. Practical medicine and sacred protection occupy the same room. Clay tablets preserve hundreds of medical instructions. Some describe swellings, skin lesions, eye problems, digestive complaints, fever, childbirth, and wounds. Ingredients include plants, minerals, oils, beer, wine, milk, animal products, and substances whose identities remain uncertain. Treatments may be swallowed, applied to the skin, inserted into the body, burned as fumigation, or wrapped beneath bandages. The evidence remains incomplete because many terms cannot be translated with confidence, and a single ancient name may refer to several possible plants. Surgical intervention appears more clearly in legal texts. The Code of Hammurabi, compiled in Babylon during the 18th century BCE, contains several laws governing physicians who use a bronze knife on patients. If a surgeon performs a major operation on a high-status man and saves his life, or successfully treats the eye, he receives a substantial payment. If the patient belongs to a lower social rank, the reward is smaller. If the patient is enslaved, compensation may be paid by the owner rather than by the patient. Medicine is therefore valued, but its value is measured according to the social hierarchy of the city. Failure can bring terrifying consequences. If a surgeon operates on a free man with a bronze knife and causes his death, or destroys his eye, the law states that the surgeon's hands may be cut off. If the patient is enslaved, the punishment becomes financial replacement rather than mutilation. The contrast is brutal, but it reveals how deeply medical responsibility is tied to class. The body of an elite citizen is legally worth more than the body of a slave, and the surgeon's risk changes accordingly. Scholars still debate how literally and frequently such punishments were applied. Ancient law codes can express ideals of royal justice rather than ordinary courtroom practice. Some penalties may be formulaic or designed to dramatize the king's authority. There is little evidence showing that surgeons routinely lost their hands after unsuccessful operations. Even so, the law communicates something real. Major surgery is recognized as dangerous, expensive, and serious enough to require public regulation. The reference to a bronze knife is also important. Metal tools allow sharper, more durable edges than many everyday materials, though obsidian can still be sharper at the microscopic level. A bronze blade can open skin, drain a swelling, cut away damaged tissue, or operate on the eye, but bronze is not stainless, and instruments may be reused without effective sterilization. A blade can carry contamination from the environment or from an earlier patient. Mesopotamian healers have no germ theory, but some may notice that clean tools and washed wounds fare better than filthy ones. Eye surgery appears to have been especially prestigious and dangerous. The legal text refers to opening the temple or eye area with a bronze instrument, though the exact procedure remains debated. It may involve treating cataracts, draining infection, or addressing trauma around the eye. Later ancient traditions use a technique known as couching, in which the clouded lens is displaced from the visual axis with a needle. Whether the Babylonian law describes the same operation is uncertain. What is clear is that the eye is valuable enough for success to bring a high fee and failure to bring ruin. Other procedures probably include lancing abscesses, cleaning wounds, removing foreign objects, treating fractures, and cauterizing diseased tissue. Abscess drainage may be one of the most effective operations available. A swollen pocket of pus can cause fever, spreading infection, and death. Opening it allows pressure and infected material to escape. The surgeon may not understand microbes, but the visible improvement after drainage is difficult to ignore. Such procedures create practical traditions because the connection between action and recovery can be immediate. Wound treatments often involve washing, bandaging, and the application of oils or plant mixtures. Beer and wine may serve as carriers for medicines and may offer limited cleansing effects, depending on their strength. Oils protect tissue but can also trap dirt, salt, resins, and certain plants may reduce bacterial growth, though many mixtures are ineffective or harmful. The patient's fate depends on the type of wound, depth of contamination, blood loss, and natural resistance as much as on the healer's skill. Diagnosis in Mesopotamia is often based on signs. The healer observes the patient's skin, breath, pulse-like movements, posture, pain, urine, stool, appetite, and dreams. Omens may be drawn from the day symptoms begin, the direction from which an animal appears, or other events surrounding the illness. To modern eyes, these signs mix careful observation with unrelated symbolism. Yet the structured collection of symptoms can still produce useful patterns. A patient who cannot speak after a blow to the head is in greater danger than one who remains alert. A wound that turns black and smells foul is worse than one that stays dry and closes. The surgeon's reputation must matter enormously in a city where payment and punishment depend on outcome. Patients and families likely seek practitioners known for success. Knowledge may pass through households or apprenticeships. A young healer learns not only how to hold a blade, but when not to use it. The safest surgeon is not always the boldest. Refusing an impossible operation may protect both patient and practitioner, though desperation can make refusal difficult when a wealthy household demands action. The laws also imply that surgery is a business. Fees are negotiated or standardized. The patient's status affects payment. An unsuccessful result can lead to compensation. Medical care is therefore part of the urban economy, shaped by wealth and legal privilege. A powerful man can summon a skilled practitioner quickly. A poor labourer may rely on cheaper treatment, household remedies, or no treatment at all. The earliest cities create not only specialists, but unequal access to them. Mesopotamia leaves no surviving surgical manual comparable to a modern textbook. Much of the knowledge remains hidden inside damaged tablets, ambiguous terms, and laws written from the viewpoint of rulers. What survives in the record suggests a profession caught between necessity and fear. The surgeon is respected because few people are willing or able to place a blade against living flesh. He is feared because the result can be death. He is regulated because his skill has economic and social consequences. In the crowded cities of clay and brick, surgery becomes more than an act of healing. It becomes a contract. A patient offers payment and trust. A surgeon offers judgment and risk. Between them lies a bronze blade, sharp enough to save an eye, open a wound, or destroy a career. The law cannot make the operation safer, but it ensures that failure will not remain a private matter. For the ancient Mesopotamian healer, every incision carries two dangers: what may happen to the patient, and what may happen to the hands that hold the knife. Farther east, along the rivers and trade routes of the Indian subcontinent, surgery develops into one of the most detailed medical traditions of the ancient world. Here the surgeon is not merely a wound dresser or emergency craftsman. He is expected to understand instruments, anatomy, preparation, aftercare, and the difference between an operation worth attempting and one likely to end in disaster. Much of this tradition becomes associated with the Sushruta Samhita, a Sanskrit medical compilation whose surviving form reflects layers of knowledge assembled and revised over many centuries. Its precise date remains debated, but the material preserves an early and unusually systematic vision of surgical practice. The figure of Sushruta stands at the centre of this tradition, though separating one historical teacher from later additions is difficult. He's presented as a physician and surgical authority connected with the city of Varanasi, where students gather to learn medicine through disciplined instruction. The text attributed to his school describes hundreds of conditions, numerous operations, and a wide range of instruments. It does not represent a single moment frozen in time. Instead, it appears to preserve knowledge accumulated, edited, and transmitted by generations of practitioners. What makes the tradition remarkable is its insistence that surgery requires training before contact with a living patient. Students are told to practice incisions on vegetable, gourds, leather bags, animal tissues, and other materials that imitate the resistance of skin or flesh. Probing can be learned through worm-eaten wood or hollow stalks. Scraping can be practiced on hairy hides. Stitching can be rehearsed on cloth or skin. These exercises are simple, but the principle behind them is sophisticated. The hand should acquire control before it is trusted with the human body. The surgeon must also know the instruments. The Sushruta tradition describes blades, needles, forceps, probes, tubes, hooks, saw-like tools, and devices designed for extraction or drainage. Many are compared with the beaks, jaws, or mouths of animals, giving craftsmen recognizable forms to reproduce. Some instruments are sharp, meant to cut, puncture, or scrape. Others are blunt, designed to grasp, explore, widen, or remove foreign objects. The division reflects a growing awareness that different tissues and problems require different tools. Cleanliness is repeatedly emphasized. Although ancient practitioners do not understand infection through germ theory, instruments are to be kept clean and sharp. The patient may be washed and prepared. The operating area is cleared of unnecessary disturbance. Wounds are dressed, monitored, and treated according to their appearance. Smoke, heat, oils, wine, honey, herbal preparations, and bandages may be used in different circumstances. Not every treatment is effective, and some may introduce new danger, but the attention to preparation and aftercare suggests that surgeons recognize how often the outcome depends on more than the incision itself. One of the most famous procedures associated with this tradition is nasal reconstruction. In ancient India, the loss of the nose can occur through warfare, accident, disease, or judicial punishment, because the face carries social identity. The injury is not merely physical, it marks a person publicly and permanently. Reconstructive surgery offers a partial answer. A flap of skin is cut from the cheek or forehead, shaped, and positioned over the missing portion of the nose while remaining attached long enough to preserve blood supply. Small tubes may be inserted to keep the nostrils open during healing. The exact methods change over time, and later Indian techniques are documented more clearly than the earliest ones. Even so, the underlying principle is extraordinary. The surgeon understands that transplanted tissue survives more reliably when it remains connected to living circulation. He may not know the microscopic biology of blood vessels, but he knows from experience that a completely detached piece of skin often dies, while a connected flap can unite with the injured area. This is reconstructive surgery based on careful observation rather than modern theory. The operation is far from safe. Tissue can become infected or necrotic. The flap can shrink, distort, or fail to attach. The patient can bleed heavily. Breathing may be obstructed, and yet even an imperfect reconstruction can restore part of the face and reduce the social stigma of mutilation. Centuries later, European observers encounter versions of Indian nasal reconstruction and recognize techniques that their own surgeons have largely lost or never developed in the same form. The Sushruta tradition also discusses the treatment of wounds, fractures, dislocations, abscesses, bladder stones, intestinal injuries, and eye disease. Some procedures are practical and recognizable. Abscesses are opened and drained. Foreign objects such as thorns, arrowheads, or fragments are removed. Fractured bones are realigned and immobilized with splints and bandages. Dislocated joints are manipulated back into position. Wound edges can be brought together using sutures made from plant fibers, hair, or other materials. A particularly striking method describes closing certain wounds with the jaws of large ants. The insects are allowed to bite across the edges of the wound, after which their bodies are removed while the heads remain locked in place like crude staples. Similar practices are known from several cultures. The method is limited and unsuitable for many injuries, but it reveals the willingness of ancient healers to use the mechanical properties of living organisms as medical tools. Bladder stone surgery is among the most dangerous procedures described. Stones can block urine, cause agonizing pain, and lead to infection or death. When other treatments fail, the surgeon may attempt to remove the obstruction through an incision near the perineum. The text warns that the operation is hazardous and should be undertaken only in desperate circumstances. Without reliable anesthesia, antisepsis, or control of internal bleeding, the risk is enormous. Damage to the bladder, rectum, vessels, or reproductive organs can be fatal. Cataract treatment is another procedure associated with ancient Indian surgery. Using a slender instrument, the practitioner attempts to push the clouded lens away from the visual axis, a technique later known as couching. The operation does not restore normal sight, because the lens remains displaced and the eye loses much of its focusing ability. It may, however, allow a patient who sees only darkness or blurred light to perceive shapes again. Complications include infection, inflammation, bleeding, glaucoma, and complete blindness. The evidence remains incomplete regarding exactly when and how widely the technique is practiced. but its inclusion demonstrates the extraordinary confidence of surgeons working near one of the body's most delicate organs. Pain control relies on imperfect methods. Wine is recommended in some contexts to dull awareness, and cannabis or other plant preparations may have been used, though the details and effectiveness are uncertain. A strong patient may be restrained by assistance. The surgeon's speed and preparation matter greatly. A prolonged operation increases exhaustion, blood loss, and movement, yet haste can cause irreversible injury. The best practitioners must balance decisiveness with restraint. The medical tradition does not separate surgery entirely from religion or broader theories of bodily balance. Health is understood through systems involving bodily substances, diet, season, temperament, and environment. Ritual preparation and ethical conduct may accompany technical practice. The surgeon is expected to be disciplined, observant, clean, and morally responsible. Skill without judgment is dangerous, while confidence without training can kill. Social access remains unequal. Royal courts, wealthy households, soldiers, merchants, and urban populations may reach skilled specialists more easily than isolated villagers or the poor. Some procedures require assistance, instruments, clean space, and prolonged aftercare, all of which demand resources. A reconstructed nose or extracted bladder stone therefore represents not only medical knowledge, but an entire network of craft production, nursing, food, and protection during recovery. No single surviving text can reveal how often these operations succeed. Prescriptive writing describes what practitioners believe should be done, not necessarily what happens in every case. Some techniques may be idealized, others may be used rarely. Scholars still debate the dating of individual passages and how closely the written tradition reflects everyday practice. Yet the detail is too extensive to dismiss as imagination alone. It describes the habits of people who know how tools behave against tissue, and how quickly a wound can turn from manageable to fatal. In the Indian surgical tradition, ancient medicine moves beyond emergency improvisation toward formal method. The student practices before cutting. The instrument is chosen for a specific task. The patient is prepared, operated on, bandaged, and observed afterward. Reconstruction becomes possible, not merely removal. Surgery is still painful, dangerous, and surrounded by uncertainty. But it is increasingly treated as a discipline that can be taught. The steady hand is no longer enough by itself. It must be guided by memory, judgment, and a body of knowledge large enough to survive the death of any single healer. As surgical knowledge moves westward into the Greek world, the body begins to be discussed in a different language. Illness is still surrounded by temples, offerings, dreams, and divine associations, but some physicians increasingly search for causes within nature itself. Wounds are examined as physical events. Fractures are compared by shape and severity. Swelling, fever, bleeding, pain, and loss of movement are treated as signs that can be studied rather than messages that must only be interpreted. The change is gradual and incomplete, yet it gives surgery a new intellectual foundation. The knife remains dangerous, but the hand holding it is now guided by an expanding effort to explain what lies beneath the skin. Greek medicine is not a single school or system. It develops across islands, colonies, city-states, military camps, athletic grounds, temples, and private households. Some healers travel from place to place, building reputations through successful treatment. Others work within families, passing skills from father to son or teacher to apprentice. Temple medicine remains important, especially at sanctuaries associated with Asclepius, where patients seek healing through ritual purification, sleep, offerings, and sacred interpretation. At the same time, practical physicians treat injuries that cannot wait for divine dreams. War provides many of those injuries. Greek warfare brings spears, swords, arrows, stones, and heavy shields into close contact with the human body. Hoplite combat can produce deep punctures, shattered limbs, crushed ribs, and wounds contaminated by cloth, soil, and fragments of armor. Naval battles add falls, burns, and drowning. Athletic competition creates dislocations, fractures, torn muscles, and head trauma. The physician who serves soldiers or athletes gains repeated experience with the mechanical failure of the body. The writings associated with Hippocrates preserve part of this practical tradition. They are not the work of one man, and scholars still debate the authorship and dating of individual texts. Together, however, they reveal physicians interested in careful observation, prognosis, and treatment based on recurring patterns. Several works focus heavily on fractures, joints, head wounds, ulcers, and the use of bandages. Their tone is often direct. The healer is expected to look closely, understand the direction of force, and recognize when intervention is likely to help. Fracture management becomes especially systematic. A broken limb must be examined for shortening, rotation, swelling, and displacement. Traction is used to draw the fragments back into alignment. Assistants pull while the physician manipulates the bone by touch. Splints and layered bandages hold the correction in place. The bindings must be adjusted as swelling changes. If they are too loose, the fracture moves. If they are too tight, the limb becomes painful, numb, discolored, and potentially dead. The physician is warned to watch the fingers or toes for signs of lost circulation, even though blood flow is not yet understood in modern terms. Dislocations require equally precise handling. The shoulder can be forced back into place through several methods involving leverage, pressure, and controlled traction. Some techniques use the physician's heel, a wooden support, or the edge of the bench as a fulcrum. These methods can appear brutal, but the underlying reasoning is mechanical. The joint has left its normal position, and force must be applied in the correct direction to return it. The practitioner must know when the obstruction is muscle tension, swelling, or broken bone. A failed reduction can worsen the injury or tear vessels and nerves. Head wounds demand caution. Greek surgical texts classify skull injuries by appearance and cause. A blow from a sharp weapon differs from a broad impact. A visible crack may extend farther than expected. Bone can be depressed inward without an obvious open wound. In some cases, trepanation is recommended to remove damaged bone or prevent dangerous pressure. Specialized drills and saws are described, including instruments designed to limit excessive penetration. The surgeon is repeatedly warned not to injure the membrane beneath the skull. Yet the understanding of the brain remains incomplete. Some Greek thinkers recognize that the brain is connected to sensation, movement, and thought, while others place the center of intelligence in the heart. These competing ideas persist for centuries. Practical experience can reveal that head trauma causes paralysis or confusion without settling the philosophical argument. Surgery advances unevenly because accurate observation does not always produce an accurate theory. Greek physicians also pay close attention to wounds. Fresh injuries may be cleaned, brought together, and bandaged. Wine is sometimes used for washing, perhaps because experience suggests that it leaves certain wounds in better condition than dirty water. Honey, oils, vinegar, plant preparations, and dry dressings appear in different treatments. Some wounds are deliberately kept open to allow drainage. Others are closed with sutures or adhesive materials. The healer looks for swelling, discoloration, pus, fever, foul odor, and spreading inflammation. The presence of pus is interpreted inconsistently. In later traditions, certain forms of thick, pale discharge are sometimes considered part of healthy healing, while thin, dark, foul material signals danger. This distinction is based on appearance rather than microbial understanding. An abscess that drains may indeed improve, creating the impression that pus itself is beneficial. What the physician sees is the turning point after pressure has been released, not the hidden infection that produced it. Cautery remains an important tool. Heated metal can stop bleeding, destroy diseased tissue, or close a wound that resists other treatment. Greek medical thought preserves a severe principle: what medicines do not heal may be treated by the knife, and what the knife does not heal may be treated by fire. The statement reflects both therapeutic ambition and the limits of available options. Fire is not subtle, but it can accomplish what pressure and bandaging cannot. Internal surgery remains rare. Opening the abdomen or chest usually leads to hemorrhage, contamination, and death. Physicians therefore concentrate on accessible parts of the body skin: limbs, joints, skull, eyes, teeth, and visible wounds. Bladder stones may be removed by specialists, but the famous Hippocratic Oath warns some physicians not to cut for stone and to leave that operation to practitioners trained specifically for it. This suggests that surgery is becoming divided into areas of expertise. It also reflects the extreme danger of the procedure. The oath's warning has sometimes been interpreted as evidence that physicians considered surgery beneath them, but the reality is more complex. Many Hippocratic texts are intensely surgical. The distinction may be between general practitioners and specialists rather than between respectable medicine and manual work. A healer who treats fever and diet may not possess the skill required to cut into the urinary tract. Referring the patient can be an act of caution rather than contempt. Anatomical knowledge develops slowly because human dissection is limited or socially restricted in many Greek communities. Physicians learn from wounds, animal dissection, and visible structures. They can identify tendons, bones, joints, membranes, and major vessels, but internal relationships are often misunderstood. Animal anatomy is sometimes projected onto humans, leading to errors that persist because few opportunities exist to correct them. A major turning point comes in Hellenistic Alexandria, where some scholars appear to conduct systematic human dissection and perhaps vivisection of condemned prisoners, though later reports are disputed and may be exaggerated. Herophilus and Erasistratus study the brain, nerves, organs, and vessels with a level of detail previously difficult to achieve. They distinguish certain nerves from tendons and explore the structure of the nervous system. Their writings survive only in fragments quoted by later authors, leaving the full extent of their discoveries uncertain. Even improved anatomy does not immediately transform surgery. Knowing the location of an organ does not provide anesthesia, antisepsis, blood transfusion, or a reliable way to control deep hemorrhage. The surgeon can understand more and still remain unable to operate safely inside the body. This contradiction will follow surgery for centuries. Knowledge advances faster than the power to intervene. Greek surgery therefore occupies an uneasy threshold. It is increasingly rational, specialized, and attentive to anatomy, yet it remains confined by pain, blood loss, and infection. Its greatest achievements often lie not in spectacular operations but in disciplined restraint aligning a limb correctly, recognizing a fatal skull injury, draining a wound, or refusing a procedure that will almost certainly kill. The ancient surgeon's intelligence is measured not only by where the knife enters, but by the moment when it stays sheathed. The Roman world inherits much of Greek medicine, but it places that knowledge inside an empire built on roads, armies, mines, ports, and permanent military frontiers. Surgery becomes less confined to individual healers, travelling between cities, and more closely tied to institutions that must keep large numbers of people alive and working. Roman physicians still rely heavily on Greek theory, and many of the most respected medical writers in the empire are Greek-speaking. Yet Rome provides something different scale. Its wars produce a constant stream of injuries, and its administrative system creates places where those injuries can be treated repeatedly, observed, and recorded. A Roman soldier lives in a world of sharp iron, heavy equipment, forced marches, disease, and sudden violence. Even outside battle, he can be injured building roads, digging fortifications, handling animals, cutting timber, or working in quarries. In combat, spears penetrate deeply, arrows lodge beneath muscle, swords open the abdomen or face, and sling stones fracture the skull. Armor prevents some wounds while changing the form of others. A blow that might cut bare flesh can instead crush tissue beneath metal, or drive fragments of equipment into the body. Military medicine must therefore be practical. The healer has little time for abstract debate when wounded men arrive together. Bleeding must be controlled, weapons and splinters must be removed, fractures must be stabilized, wounds must be washed, inspected, and dressed. Patients who are likely to survive need attention before those beyond help consume scarce time and supplies. Roman sources do not describe a modern system of battlefield triage, but organized armies inevitably develop rough methods of priority based on urgency, rank, and expected survival. Permanent forts along the frontiers sometimes include buildings identified as valetudinaria, military hospitals designed around courtyards with rows of small rooms. Archaeological examples are found in several parts of the empire, especially in regions where legions remain stationed for long periods. These structures suggest that sick and wounded soldiers can be separated from crowded barracks and treated in a more controlled environment. They are not hospitals in the modern sense. There are no sterile wards, trained nursing staffs, or effective antibiotics. Still, they provide shelter, water, storage, and space for observation. all of which improve the chances of recovery. The Roman army also values specialized medical personnel. Titles preserved in inscriptions suggest different levels of responsibility, including physicians attached to legions, auxiliary units, ships, and perhaps particular categories of treatment. The exact organization changes over time and remains imperfectly understood. Some practitioners may be formally appointed, while others gain status through experience. A surgeon who repeatedly treats arrow wounds becomes better at locating embedded points. Another who works with cavalry learns the fractures produced by falls and crushing injuries. Roman surgical instruments survive in unusual numbers. Bronze and iron scalpels, forceps, probes, hooks, needles, cautery tools, bone levers, catheters, and specula have been recovered from houses, military sites, graves, and medical collections. Their forms are often elegant and highly specialized. A typical scalpel may have a bronze handle with an iron or steel blade inserted at one end and a blunt probe at the other. The blade cuts tissue, the probe explores a wound, separates structures, or applies medicine. Combining both functions in one instrument makes practical sense for a traveling physician. Forceps vary in size and shape. Some are designed to grasp tissue, while others may remove fragments, teeth, or foreign objects. Fine hooks can lift skin or expose small structures. Broad hooks provide stronger traction. Tubes and catheters allow access to passages that cannot be reached safely with a blade. Needles support suturing, although the choice of thread and technique depends on the wound. Saws and bone-cutting tools make amputation and the removal of damaged bone possible, though both procedures remain terrifyingly dangerous. The apparent sophistication of the instruments should not be mistaken for proof of safe surgery. A beautifully made tool can still introduce infection. Bronze may be washed and polished, but it is not sterilized by modern standards. Iron blades corrode. Handles accumulate organic material in grooves and joints. Instruments used on several patients can carry contamination even when they appear clean. Roman surgeons understand visible dirt, foul smell, decay, and the danger of corrupted wounds. But the invisible cause remains beyond them. Wound cleaning often uses water, wine, vinegar, oils, and plant preparations. Wine and vinegar may reduce some microbial contamination, especially compared with stagnant water, though their effectiveness depends on concentration and use. Honey appears again as a dressing ingredient. Resins can create barriers and may have limited antimicrobial properties. Wool or linen absorbs blood and protects the injury, but reused material can spread infection. The same treatment that helps one patient may harm another because the underlying contamination differs. Arrow extraction becomes an important surgical skill. A barbed point cannot always be pulled backward without tearing more tissue. The surgeon may enlarge the wound, push the point through, or use a specialized instrument to protect surrounding flesh during removal. Probes help determine the depth and direction of the shaft. The operation demands judgment because a weapon lodged near a major vessel may be less dangerous left in place than removed once it is disturbed. Bleeding can become uncontrollable. Roman medical writers describe methods for dealing with projectiles and other foreign objects, but the written instructions may not represent ordinary battlefield practice everywhere. Celsus, writing in the early imperial period, preserves extensive discussions of surgery in Latin. His work covers wounds, fractures, dislocations, abscesses, amputations, bladder stones, cataracts, and procedures involving the skin and body cavities. He is not necessarily a practicing surgeon, and scholars still debate his precise role. Yet his descriptions reveal the level of surgical knowledge circulating within the Roman world. Celsus presents the ideal surgeon as young, or at least steady-handed, ambidextrous, sharp-eyed, courageous, and unmoved by the cries of the patient. The description is severe because the operation itself is severe. The patient may struggle, faint, or beg for the procedure to stop. The surgeon cannot allow sympathy to ruin the necessary movement, but neither can he cut recklessly. He must be fast without becoming careless and decisive without becoming blind to danger. Amputation stands at the edge of what Roman surgery can achieve. A limb destroyed by crushing injury, gangrene, or severe infection may threaten the patient's life. Removing it offers a small chance of survival, but the operation causes massive pain and blood loss. The surgeon cuts through skin and muscle, controls vessels as best as possible, saws the bone, and treats the stump with ligatures, pressure, cautery, or a combination of methods. There is no reliable way to replace lost blood. Shock can kill even when the operation itself is technically successful. Cautery is used frequently because heat can seal vessels and destroy diseased tissue. Heated instruments come in different shapes suited to different parts of the body. The smell, smoke, and pain must be overwhelming. Yet when bleeding refuses to stop, fire may be the only available tool. Roman surgery repeatedly chooses between immediate suffering and near-certain death. Bladder stone surgery also continues. The patient is restrained, the stone is located by touch, and an incision is made through the perineal region to reach and extract it. The operation is reserved for desperate cases because damage to the urinary tract, rectum, vessels, or reproductive organs can be fatal. Even successful patients face infection and chronic leakage. Specialists may perform the procedure because repetition is the only path to competence. Eye surgery includes cataract couching, in which a needle displaces the clouded lens. Some patients regain a limited ability to perceive light and shapes, while others lose the eye entirely. Dental extraction is performed with forceps, though badly infected teeth may break during removal. Abscesses are opened and drained. Hernias, hemorrhoids, and fistulas receive treatments ranging from ligature to cautery, often with uncertain results. What survives in the record suggests that Roman expansion spreads medical techniques alongside roads, forts, and settlements. Local healing traditions do not disappear, and Roman practitioners borrow from them in return. Plants, instruments, and methods move across provinces. A surgeon in Britain may carry ideas developed in the Mediterranean, while remedies from Gaul, Egypt, or Asia Minor enter wider use through military and commercial networks. The Roman achievement is therefore not a single revolutionary operation. It is the creation of a vast environment in which surgery is practiced repeatedly, supported by specialized tools and military organization. The empire does not conquer infection, pain, or blood loss. It does, however, turn surgical knowledge into something portable. A case of instruments can cross a continent. A physician can move from one frontier to another. A wounded soldier in a cold northern fort may be treated with methods whose intellectual roots reach back through Greece, Egypt, and lands even farther east. On the frontier, surgery becomes part of the imperial survival. Fortifications, roads, and discipline keep armies in place, but injured bodies must also be repaired. The Roman surgeon works where civilization meets violence, using polished instruments in rooms that still smell of blood, vinegar, smoke, and damp wool. His tools appear refined enough to belong to a later age, yet every operation remains bound by ancient limits. He can reach the wound, remove the weapon, and close the flesh. What happens afterward is still left to the strength of the patient, the care of others, and forces no Roman physician can yet see. Before any ancient surgeon touches a blade to living flesh, another problem fills the room. The patient is awake. There is no reliable general anesthesia, no controlled dose delivered through a mask, and no monitor showing whether breathing or heartbeat has begun to fail. Pain is not a complication that appears after the operation begins. It is present from the first incision and can shape every movement that follows. A patient who jerks suddenly can turn a careful cut into a fatal one. A person overwhelmed by fear may resist before the surgeon reaches the wound. For ancient surgery to happen at all, pain must be reduced, endured, restrained, or absorbed into a ritual powerful enough to keep the body still. The simplest method is physical restraint. Assistants hold the patient's arms, legs, shoulders, or head while the surgeon works. Straps, cloth bindings, or the weight of other bodies may be used when the operation requires precision. Roman descriptions of surgery assume that the patient's movement is a constant danger, and the ideal surgeon is praised for remaining steady despite cries and struggling. Similar realities must exist much earlier, even when written evidence is absent. A trepanation performed with a stone scraper, a bladder stone removed through the perineum, or an arrowhead cut from deep muscle cannot be completed if the patient is free to twist away. Restraint, however, does not lessen the pain itself. Ancient healers therefore turn to substances that dull awareness. Fermented alcohol is among the most widely available. Beer, wine, mead, and other drinks can calm fear, reduce inhibition, and make a patient less responsive. Large quantities may produce stupor or unconsciousness. yet alcohol is unreliable. The strength of the drink varies, and the amount needed to dull severe pain can also cause vomiting, dangerous breathing, dehydration, or loss of control. An intoxicated patient may still react violently when the blade enters. Wine sometimes serves several purposes at once. It may be consumed before the operation, poured over a wound, mixed with herbal medicines, or used afterward to encourage sleep. In cultures where wine is associated with ritual and hospitality, drinking it before surgery may also have psychological meaning. The patient enters the procedure altered not only physically but socially, surrounded by familiar tastes, attendants, prayers, and expectations. Fear can intensify pain, and anything that creates confidence may offer limited relief, even when the chemical effect is weak. Opium provides a more powerful possibility. Derived from the poppy, it contains compounds capable of reducing pain and causing sedation. Evidence for poppy cultivation and medicinal use appears in several ancient regions, though tracing exactly how opium is prepared and administered is difficult. It may be swallowed, mixed into drinks, or included in compounds with other plants. The problem is dosage. Too little offers little relief, too much slows breathing and can kill. Without standardized extracts, the strength depends on the plant, growing conditions, storage, and preparation. The healer measures by experience rather than precise chemistry. Mandrake is another plant repeatedly associated with pain relief and sleep. Its root contains substances that can cause sedation, confusion, dry mouth, blurred vision, hallucinations, and unconsciousness. In larger quantities, it becomes dangerously toxic. Ancient texts describe mandrake in medical and magical settings, making it difficult to separate practical use from symbolism. A preparation may reduce pain, but it may also produce delirium or fatal poisoning. Scholars still debate how consistently such plants were used during operations and whether later accounts exaggerate their effectiveness. Cannabis may also play a role in certain regions. It can reduce anxiety and alter the perception of pain, though its effect is not strong enough to make major surgery painless. Other plants, including henbane, nightshade, and various local herbs, contain chemicals that influence consciousness. Some can be applied to the skin, burned as smoke, or swallowed in mixtures. The evidence remains incomplete, and ancient drug names are often difficult to identify. A translated word may refer to several species, while one plant may carry different names across time and place. Combining substances can deepen sedation but also multiply danger. Wine mixed with opium or toxic herbs may render a patient unresponsive, yet no one can measure oxygen levels or reverse an overdose. If breathing becomes shallow, the healer has few options beyond stimulation, repositioning, or waiting. A patient who dies from the medicine may be indistinguishable in the historical record from one who dies from the operation. Local pain relief is even harder to achieve. Cold can numb tissue temporarily. Snow, ice, or chilled water may reduce sensation where climate and season allow, though prolonged cooling damages skin and cannot reach deep structures. Compression of a nerve or blood vessel can create temporary numbness in a limb, but the technique is uncertain and dangerous. Some plant pastes may irritate or dull the skin, yet their effect is limited. Ancient surgeons generally cannot block pain at its source in the controlled manner of modern local anesthesia. Speed therefore becomes a form of mercy. The longer an operation lasts, the longer the patient suffers and the greater the chance of movement, bleeding, exhaustion, and collapse. A skilled surgeon prepares tools in advance, positions assistants, and rehearses the sequence mentally. Incisions are direct. Foreign objects are removed without unnecessary exploration. Amputations, when unavoidable, must be completed rapidly. Yet speed has limits. A hurried blade can cut an artery, nerve, or organ. The best surgeon is not merely fast, but economical, making as few movements as possible. Pain itself can kill indirectly. Severe distress contributes to shock, though ancient practitioners do not understand its full physiology. A patient may become pale, cold, weak, confused, and unresponsive. Blood loss worsens the collapse. So do fear, dehydration, infection, and prolonged trauma. Ancient texts sometimes describe these outward signs without knowing how they connect. The surgeon sees that a patient who stops crying and becomes quiet may not be improving. Silence can mean strength is disappearing. Ritual becomes another tool against fear. Prayers, chants, incense, amulets, and sacred preparations may seem separate from surgery, yet they shape the patient's state of mind. A trusted healer who explains suffering through a shared belief system can make the procedure feel purposeful rather than chaotic. Rhythmic chanting may focus attention. Familiar attendance may prevent panic. A patient convinced that the operation is necessary or divinely protected may remain still longer than one who expects only agony. Not every patient experiences pain in the same way. A wounded soldier already exhausted by blood loss may drift in and out of consciousness. A person with severe head trauma may be confused or insensible. An infected patient weakened by fever may offer little resistance. In emergency surgery, nature sometimes provides its own terrible anesthesia through shock, injury, or near death. The surgeon works quickly because that window can close at any moment. Social status also influences how pain is managed. Wealthy patients may receive rare drugs, experienced attendants, a clean room, and prolonged care afterward. Soldiers may have access to organized medical support but little choice about treatment. Enslaved people, laborers, and the poor may be operated on under rougher conditions or abandoned when recovery seems unlikely. Courage is praised unevenly, often by those who are not lying beneath the blade. Ancient surgery is therefore not painless surgery. At best, it is surgery performed through layers of intoxication, sedation, numbness, restraint, speed, belief, and human endurance. Some patients remember every cut, others remember fragments, dreams, or nothing at all. The methods are inconsistent and often dangerous, but they make intervention possible where otherwise the knife could never be used. The surgeon's achievement is not only technical, it is the ability to work while another human being suffers at arm's length. The patient's achievement is even more difficult to measure. Every healed amputation, reconstructed nose, opened skull, or extracted stone belongs to someone who endured what modern medicine now works hard to prevent. Their survival reveals the strength of ancient knowledge, but it also preserves the shadow beneath that knowledge. The price paid in pain before surgery learned how to silence it. Once the blade is removed and the wound is closed, the ancient surgeon's control begins to fade. The bleeding may have stopped. The broken bone may be aligned. The arrowhead may be gone. For a few hours, the operation can appear successful. Then the edges of the wound begin to redden. Heat spreads through the tissue. Swelling tightens the skin. The patient grows thirsty, weak, and restless. A foul smell may rise from beneath the dressing. Long before anyone understands bacteria, surgeons repeatedly confront an invisible enemy whose presence can be recognized only by what it does to the living body. Infection is one of the great limits of ancient surgery. Every incision creates a path through the skin, the body's strongest barrier against contamination. Dust, soil, dirty water, cloth fibers, fragments of clothing, animal matter, and material carried on the surgeon's hands or tools can all enter the wound. Battlefield injuries are especially dangerous because weapons drive debris deep into tissue. A spearhead may carry pieces of wool, leather, or dirt beneath the skin. A crushed limb may contain dead tissue where infection can spread without resistance. Even a clean-looking cut can become lethal. Ancient healers do not know that microscopic organisms reproduce inside wounds. They cannot see the chain of transmission from unwashed hand to instrument, from instrument to patient, or from one patient to another. Yet they are not blind to patterns. They notice that some wounds remain dry and close, while others become hot, wet, painful, and foul. They learn that dead tissue must sometimes be removed. They understand that trapped fluid creates pressure and that a swollen abscess may improve after it is opened. Their explanations may involve corrupted humours, poisonous air, imbalance, decay, or supernatural influence, but the practical observations can still be accurate. Cleaning is the first defence. Water removes visible dirt and dried blood, although its quality varies enormously. River water near a crowded settlement may contain waste and pathogens. Well water can be cleaner, but not always. Boiling water could reduce contamination. Yet there is little evidence that this is performed consistently for surgical purposes. The healer judges cleanliness by sight, taste, smell, and source rather than by invisible risk. Wine and vinegar are often used to wash wounds. Their acidity and alcohol content may reduce some microorganisms, especially when compared with stagnant water, though ancient wine is not a reliable disinfectant. The effect depends on strength, contact time, and the type of contamination. Still, repeated experience may show that wounds washed with certain liquids sometimes fare better. This is one of surgery's recurring patterns. A method can offer real benefit long before anyone understands the mechanism. Honey is another ancient treatment that appears in Egyptian, Greek, Roman, Indian, and other medical traditions. Thick honey draws moisture, forms a physical barrier, and can inhibit the growth of some bacteria. Its acidity and chemical properties make it more useful than many substances available to ancient healers. Yet not all honey is equally clean, and applying it with contaminated hands or cloth can defeat its benefits. Even so, its repeated use across cultures is unlikely to be explained by symbolism alone. Healers must have seen that some honey-dressed wounds smelled less foul and healed more cleanly. Plant resins, oils, and aromatic substances are also applied. Certain resins contain compounds that slow microbial growth, others simply seal the wound, which may protect it from dirt but can also trap infection inside. Oils prevent dressings from sticking and reduce drying, but they may create a warm environment where contamination thrives. Ancient wound care is therefore a mixture of useful and harmful effects, often impossible for the practitioner to separate. Metals enter treatment in several forms. Copper compounds are used in some preparations and can inhibit microbes, although they can also damage tissue. Silver later gains a reputation for preserving water and treating wounds, but its ancient medical use varies by region and period. Heated metal has a more immediate effect. Cauterization burns tissue, seals vessels, and destroys organisms at the point of contact. It can stop bleeding and reduce contamination in damaged flesh. But it also creates a new burn that must heal. Used too deeply, it kills healthy tissue and enlarges the injury. Fire offers another imperfect route to cleanliness. A blade held in flame becomes hot enough to destroy many contaminants, though ancient practitioners may heat tools primarily for cautery rather than sterilization. Instruments may also be wiped, washed, polished, or stored in cases. A well-maintained surgical kit is likely safer than a rusty blade carried loose among other objects, even if no one understands why. The difference between careful and careless practice can therefore become visible in survival rates. Drainage is among the most effective ancient responses to infection. A closed abscess traps pus under pressure. The surrounding tissue becomes swollen and painful, while fever may spread through the body. Opening the abscess allows material to escape. The cavity can be washed, packed, or left open. The operation is simple compared with trepanation or amputation, yet it may save more lives than many dramatic procedures. The surgeon learns that closing every wound is not always wise. Some wounds must remain open until corruption has drained away. This creates a difficult judgment. A fresh, clean cut often heals better when its edges are brought together. A contaminated wound can become more dangerous if sealed. Without knowledge of bacteria, the surgeon relies on appearance, cause, smell, and experience. A wound from a clean blade differs from one made by an animal bite or dirty projectile. A crushing injury differs from a shallow incision. What survives in ancient medical writing suggests that some practitioners recognize these distinctions, even if their rules remain inconsistent. Dead tissue presents another threat. Flesh deprived of blood darkens, softens, and begins to decay. If left in place, it provides an environment where infection can flourish. Ancient surgeons sometimes cut away damaged tissue, scrape ulcers, or amputate a limb when decay spreads. They may describe the process as rot, corruption, or gangrene. The outward signs are unmistakable blackening skin, loss of sensation, foul discharge, fever, and advancing death. Amputation can halt the spread only if performed above the affected tissue, and before infection overwhelms the body. The operation itself introduces new contamination and severe blood loss, so the decision is desperate. Ligatures may close vessels. Pressure and cautery may control bleeding. The stump can be dressed with wine, vinegar, honey, oils, or herbs. Even when the patient survives the first day, infection can return through the new wound. Tetanus is one danger ancient surgeons cannot identify as a distinct microbial disease, though its symptoms are recognizable. A person with a contaminated puncture wound may later develop stiffness, painful spasms, and a locked jaw. The original injury can seem minor, By the time the body begins to convulse, treatment is largely powerless. Other infections cause spreading redness, fever, delirium, organ failure, or rapid death. Surgeons can observe these patterns without knowing that different organisms are responsible. Not all pus is interpreted as failure. Some Greek and Roman traditions distinguish between thick, pale discharge associated with a wound that is localizing and thin, dark, foul material associated with deterioration. Later physicians sometimes speak of laudable pus, believing certain forms are part of healthy healing. The conclusion is mistaken, but it grows from a real observation an abscess that drains may improve, while infection trapped deep inside may kill. The healer associates visible pus with recovery because the dangerous material has finally found a way out. Environment affects survival as well. Dry climates may slow some forms of contamination and keep dressings from remaining wet. Heat can worsen decay. Cold may preserve tissue but weaken patients. Crowded hospitals or military camps allow infection to move between wounded people through hands, cloth, tools, insects, and shared water. A surgeon who treats several patients in succession can spread disease while believing he is helping each one independently. Nursing becomes as important as the operation. Dressings must be changed. Wounds must be watched for smell, heat, swelling, and color. Patients need water, food, warmth, and rest. Flies must be kept away. A successful incision followed by neglect can still end in death. The ancient surgical team therefore includes people whose names rarely appear in text's attendance, family members, enslaved workers, soldiers, and women responsible for washing, feeding, and bandaging. Scholars still debate how consciously ancient practitioners connected cleanliness with survival. The evidence varies across cultures and periods. Some texts demand careful washing and clean materials. Others recommend substances that are dangerous or contaminated. There is no steady march toward antisepsis. Knowledge advances, disappears, and reappears according to local traditions and individual skill. The invisible enemy remains invisible, but its consequences shape every surgical decision. It limits how deeply the body can be opened, how long a wound can remain exposed, and how ambitious a surgeon can afford to be. Ancient operators learned to cut where the body can recover, drain where pressure builds, burn where bleeding cannot be controlled, and avoid cavities where contamination is almost always fatal. They do not conquer infection, they circle it cautiously, recognizing its footprints in heat, odor, swelling, and death. For every healed skull or successful reconstruction preserved in the archaeological record, many other patients vanish without evidence, their operations ending not beneath the blade but days later beneath a soiled dressing. The ancient surgeon may leave believing the procedure has succeeded, only to return and find fever spreading through the body. The wound has become a second illness, one created by the attempt to cure the first, until medicine learns what lives beyond sight. Surgery will remain a contest fought in darkness. The ancient surgeon's tools often survive when the surgeon's name does not. Bronze resists decay. Iron leaves stains in the earth. Bone handles, stone blades, and ceramic containers sometimes remain inside graves, houses, military forts, shipwrecks, and ruined clinics long after the hands that used them have disappeared. When these objects are found together, they form something like a silent operating kit. Their shapes reveal not only what ancient practitioners could attempt, but how specialized their work had become. A general-purpose knife may open skin, yet a narrow hook, hollow tube, toothed forceps, or guarded drill exists because someone has encountered the same difficult problem often enough to demand a better instrument. A Roman medical chest might hold scalpels with interchangeable blades, probes tipped like spoons, needles, forceps, hooks, cautery irons, and small boxes for medicines. Greek, Egyptian, Indian, and Mesopotamian traditions use their own combinations of metal, stone, wood, bone, horn, and plant material. No universal ancient surgical kit exists, and the evidence remains incomplete. Tools are often discovered without labels, while objects used in medicine may resemble those used by barbers, craftsmen, cooks, or metalworkers. Context matters. A sharp blade found alone proves little. A collection of probes, forceps, medicine containers, and cautery tools buried together strongly suggests a practitioner whose work went beyond ordinary household treatment. The scalpel is among the most recognizable instruments. Ancient blades vary in width and curve according to purpose. A broad edge can open an abscess or cut through thicker tissue. A fine-pointed blade allows smaller incisions near the eye, face, or delicate vessels. Some Roman scalpels combine an iron cutting edge with a bronze handle ending in a blunt spatula or probe. The surgeon can cut with one end, then reverse the tool to separate tissue or apply medicine. This efficiency matters when assistants are limited and every instrument must be carried from place to place. The quality of metalworking directly affects surgical possibility. Bronze is easier to cast into complex forms and resists corrosion better than ordinary iron, though it does not hold every kind of edge equally well. Iron and early steel can produce stronger blades but require careful forging and maintenance. Stone remains useful long after metal appears. Obsidian fractures into an edge of extraordinary sharpness, capable of making an extremely clean incision. It is also brittle. A fragment breaking inside a wound creates a new danger, and stone cannot easily be reshaped into the many forms possible with cast metal. Needles allow surgeons to close wounds, repair torn skin, and secure bandages. They may be made from bronze, iron, bone, or other hard materials. Some are straight, others are curved to pass through tissue more easily. Thread can come from linen, wool, plant fiber, hair, animal sinew, or gut. Each material behaves differently. Some absorb moisture and swell, others weaken or rot. Thick thread can tear delicate tissue, while thin thread may snap under tension. The surgeon must judge not only where to place the stitch, but how tightly to pull it. A wound closed too loosely can reopen. When closed too tightly, loses blood supply along its edges and may decay. Not all wounds are stitched. Certain injuries are held together with adhesive mixtures, bandages, pins, clips, or even insect jaws. Large ants used as natural staples grip the edges of a wound, after which their bodies are removed and their locked heads remain in place. The method sounds strange, yet its mechanical principle is clear. The jaws hold tissue together without requiring a needle to pass repeatedly through it. Such practices show that ancient surgery is not limited to manufactured tools. Anything with a useful shape, force, or chemical property can become part of the kit. Probes are essential because the surgeon often cannot see the full depth of a wound. A narrow metal rod can follow the path of an arrow, splinter, or blade. Rounded tips reduce the risk of creating new damage. Spoon-shaped ends remove debris or apply medicine. Some probes are marked or shaped to help estimate depth, though ancient measurement is not standardized. The surgeon learns to feel resistance through the tool. Soft tissue gives way differently from bone. A hollow space feels different from tightly packed muscle. This tactile knowledge is difficult to describe in writing and likely depends heavily on apprenticeship. Hooks allow tissue to be lifted or held aside. Fine hooks can expose a small structure. Stronger hooks pull skin, muscle, or the edge of a wound away from the surgeon's path. Their appearance can be alarming, but without them, an assistant must hold tissue with fingers, blocking the view and introducing more contamination. Some hooks are blunt to reduce tearing. Others are sharp because they must grip firmly. Choosing the wrong one can enlarge the injury. Forceps serve many purposes. They grasp splinters, arrowheads, dead tissue, teeth, stones, and fragments of bone. Smooth forceps reduce crushing, while toothed jaws hold slippery material more securely. Dental forceps require enough strength to move a tooth without breaking it. Though ancient extractions often end with fractured roots left behind, fine forceps used near the eye or within a small wound demand much greater control. Surviving examples show that ancient craftsmen can produce instruments with precise alignment, spring tension, and narrow gripping surfaces. Tubular instruments open another range of procedures. Catheters made from bronze or other materials may be inserted into the urinary passage to relieve obstruction or examine the bladder. Their curvature differs according to the anatomy of the patient. A poorly placed catheter can tear tissue, create bleeding, or introduce infection. Yet urinary retention can be fatal, and the ability to drain the bladder may save a life without open surgery. Hollow tubes also keep passages open after reconstruction, as in nasal repair, or guide fluids into and out of wounds. Specula are designed to widen natural openings so that the surgeon can see and work inside. Surviving Roman vaginal and rectal specula contain screw mechanisms or hinged blades that expand once inserted. Their engineering is sophisticated, and their use must have been deeply uncomfortable. They allow examination, cautery, treatment of fistulas, and removal of certain growths or foreign objects. The existence of such tools demonstrates a willingness to investigate parts of the body that cannot be reached with an ordinary blade. Bone surgery requires heavier equipment. Saws cut through limbs during amputation or remove damaged sections of bone. Chisels, levers, rasps, and drills help lift depressed skull fragments, smooth rough edges, or widen openings. Trepanation tools sometimes include circular drills or crown-like cutters. The greatest danger is depth. Once the instrument passes through the inner surface of the skull, a slight uncontrolled movement can damage the membrane or brain beneath. Some designs include shoulders, guards, or central pins intended to limit slipping. These features suggest that toolmakers respond directly to surgical accidents. Cautery instruments are shaped according to where heat must be applied. Some end in narrow points, others carry flat, rounded, or blade-like surfaces. They are heated in a flame or brazier until hot enough to burn tissue. The surgeon uses them to stop bleeding, destroy diseased growths, treat ulcers, or close passages. Different temperatures create different effects, though control is crude. A tool that cools too quickly fails to seal the vessel. One that is too hot destroys more tissue than intended. The operation requires coordination between the surgeon and assistants tending the fire. The kit also contains containers rather than cutting tools. Small jars and boxes hold honey, oils, resins, powders, pigments, minerals, and dried plants. Spoons and spatulas mix or apply these substances. Cloth, wool, linen, sponges, and bandages absorb blood and protect wounds. Many of these materials rarely survive archaeologically, creating a distorted picture in which metal instruments appear more important than the soft materials used with them in practice. A simple, clean dressing may contribute more to survival than the most elaborate scalpel. Maintenance is part of surgical skill. Blades must be sharpened. Iron must be protected from rust. Hinges and screw mechanisms must remain functional. Probes must be straight, needles smooth, and forceps aligned. A damaged tool tears rather than cuts. Some surgeons may own personal kits made by trusted craftsmen. Others borrow tools, improvise from household objects, or work with whatever a military storehouse or temple can supply. Wealth therefore shapes not only access to surgery but the quality of the instruments themselves. The tool does not act alone. A perfectly forged blade is useless in an untrained hand, while an experienced practitioner can accomplish much with a simple knife and probe. Still, instruments preserve the ambitions of ancient surgery. They show that healers are not merely cutting where the body appears injured, they are exploring, widening, extracting, draining, suturing, scraping, cauterizing, and reconstructing. Each specialized shape represents a problem encountered repeatedly enough to be studied and refined. Laid out together, the ancient surgical kit looks disturbingly familiar. The materials are older, the edges rougher, and the mechanisms simpler, yet the basic forms persist into modern operating rooms. Scalpel, forceps, probe, needle, catheter, retractor. So the names and precision have changed more than the underlying purposes. What separates the ancient table from the modern one is not the concept of the instrument, but everything surrounding it: anesthesia, sterilization, imaging, antibiotics, transfusion, and a deeper map of the body. The tools had arrived early. The safe world they required would take much longer to build. The most dangerous ancient operations are rarely chosen because the surgeon is confident. They are chosen because every other path appears to end in death. A limb is turning black. A bladder stone has blocked the passage of urine. A woman has laboured for days while the child remains trapped. An eye has become clouded until only light remains. In such moments, surgery does not promise recovery. It offers a final opening where none seems left. And the ancient patient enters that opening with no guarantee that pain, bleeding, or infection can be controlled. Childbirth exposes this boundary with particular cruelty. Most deliveries take place in homes, attended by experienced women whose knowledge passes through families and communities rather than formal medical schools. They recognize the stages of labor, support the mother's body, prepare warm water and cloth, and use massage, movement, oils, or changes of position to encourage delivery. Their skill can make the difference between survival and death. Yet some complications cannot be corrected from outside. A child may lie sideways, The head may be too large, the pelvis may be too narrow, the placenta may separate too early, or bleeding may continue after birth. Ancient medical texts describe methods for repositioning a fetus by hand when possible. The attendant or physician may attempt to turn the child, bring down a limb, or widen the birth passage. These procedures are painful and dangerous, especially after prolonged labour has exhausted the mother and swollen the tissues. Without a clear understanding of internal injury, the operator relies on touch. A mistaken movement can tear the uterus, damage the bladder, or cause fatal bleeding. When the fetus has died and obstructed labour continues, some traditions describe destructive operations intended to save the mother. Instruments may be used to reduce or remove the trapped body piece by piece. It is among the darkest procedures in ancient medicine, yet the logic is desperate rather than cruel. If the obstruction remains, the mother will likely die from exhaustion, rupture, hemorrhage, or infection. The operation sacrifices what can no longer be saved in an attempt to preserve the life that remains. Caesarean delivery belongs to a different category. Popular stories often imagine ancient surgeons routinely opening living women to deliver children, but the evidence does not support that picture. In most ancient settings, cutting through the abdominal wall and uterus almost certainly kills the mother through bleeding or infection. The operation is more plausibly performed after the woman has died or is believed to be dying. Either to recover a living infant or for religious and legal reasons concerning burial, rare survival may have occurred, but convincing evidence from the ancient world is extremely limited, and later accounts are difficult to verify. The very name of the operation has generated legends, including the claim that Julius Caesar was born this way. That is almost certainly false, since his mother survived long into his adulthood, something extraordinarily unlikely after abdominal delivery in that period. The association probably arises from later interpretations of Roman law or Latin terms related to cutting. The truth is less dramatic, but more revealing. Ancient surgeons understand that the uterus can be opened, yet they lack the means to make the operation reliably survivable. Bladder stones present another form of entrapment. Mineral deposits can grow inside the bladder until urination becomes painful, difficult, or impossible. The patient may suffer constant irritation, blood in the urine, infection, and agonizing pressure. Children are particularly vulnerable in some ancient populations because of diet and dehydration. When a stone is small, healers may recommend fluids, movement, diet, or herbal remedies. When it becomes too large to pass, surgery remains the only physical solution. The ancient operation, later known as lithotomy, requires the surgeon to locate the stone by touch, through the lower abdomen or rectum, and force it toward the perineum. An incision is then made near the urinary passage, and the stone is grasped and removed. The space is crowded with major vessels, nerves, reproductive structures, the rectum, and the bladder itself. The patient is restrained in a position that gives the surgeon access while increasing fear and humiliation. One incorrect cut can produce catastrophic bleeding or permanent leakage. The procedure often belongs to specialists because repeated experience matters enormously. A practitioner who performs only one or two such operations has little chance to refine technique. This may explain why general physicians in some traditions are warned to leave stone cutting to those trained for it. Even the specialist faces terrible odds. Infection can spread from the urinary tract into surrounding tissue. The wound may fail to close. Scar formation can obstruct urination again. Yet a patient already unable to pass urine may accept almost any risk. Amputation carries the same brutal arithmetic. The limb is removed not because surgeons believe the operation safe, but because leaving it attached appears more dangerous. Crushing injuries, severe burns, frostbite, battlefield wounds, and spreading gangrene can destroy tissue beyond recovery. When flesh becomes cold, black, insensible, and foul, death may already be moving toward the center of the body. The surgeon must choose where to cut. Too close to the dead tissue, an infection remains. Too far above it, a more healthy limb is sacrificed. Ligatures may be tied around vessels, though locating and securing them is difficult when the field is filled with blood. Pressure, tourniquets, and cautery help control hemorrhage. The bone is sawed through, its rough edge smoothed, and the remaining tissue drawn over the stump. Speed matters, but so does precision. A fast operation that leaves shattered bone or uncontrolled vessels offers little advantage. Survival depends on more than the incision. The patient must withstand shock, blood loss, fever, and weeks of wound care. Food and water must be provided. The stump must be protected from dirt and repeated trauma. If the individual survives, life changes permanently. A missing leg or arm affects work, status, movement, and dependence on others. Archaeological cases in which amputees live for years show that communities sometimes support people long after the dramatic moment of surgery has passed. Eye surgery is smaller in scale but no less delicate. Cataracts cloud the lens until vision fades behind a pale or grey obstruction. Couching attempts to move the lens aside with a needle inserted through the eye. The surgeon cannot restore normal sight. At best, the patient regains the ability to distinguish light, movement, and large shapes. For someone nearly blind, even that limited improvement may be transformative. The operation requires the patient to remain perfectly still, while a sharp instrument passes within millimeters of structures that cannot repair themselves easily. The lens may be pushed downward, but it can return to its original position. The needle can injure the iris, retina, or surrounding tissues. Bleeding, inflammation, infection, and increased pressure inside the eye may destroy whatever vision remains. Scholars still debate how successful ancient couching truly was because written descriptions often emphasize technique rather than long-term outcome. Other operations occupy the same narrow territory between necessity and catastrophe. Hernias may be treated with pressure, ligature, cautery, or cutting. Though opening the hernial sac risks exposing the abdominal cavity, hemorrhoids can be tied off, burned, or excised. Anal fistulas may be opened with blades or gradually cut using a thread passed through the tract. Abscesses are drained, diseased teeth are extracted, growths on the skin are removed. Each procedure appears modest compared with opening the skull, yet each can produce fatal bleeding or infection. What survives in the record suggests that ancient surgeons develop a hierarchy of risk. Surface procedures are attempted more readily. Operations near major vessels or within body cavities are reserved for cases of extreme need. The surgeon must judge not merely whether an operation is technically possible, but whether the patient has enough strength left to survive it. A procedure performed too late may be pointless. Performed too early, it may kill someone who might otherwise have recovered. There is no single ancient standard governing these decisions. Some practitioners are cautious, others are ambitious, desperate, or pressured by families and rulers. Success enhances reputation, while failure may bring disgrace, legal punishment, or violence. The patient's social status can influence whether every possible measure is attempted or whether care is withdrawn quickly. The same injury may receive different treatment in a palace, military fort, village, or enslaved household. These operations reveal the true nature of ancient surgical courage. It is not confidence that the patient will live. It is willingness to act when inaction has become nearly indistinguishable from death. The surgeon opens the body because time has run out, using touch, memory, and instruments refined through generations. Sometimes the intervention fails immediately. Sometimes the patient dies days later, and sometimes, against the limits of the age, the obstruction is removed. The bleeding stops, the wound closes, and a life continues that should have ended beneath the knife. The patients who survive these desperate procedures rarely leave written accounts. Their names vanish, their voices disappear, and the circumstances of their operations are lost. Yet the body can preserve a different kind of testimony. Bone records injury, healing, infection, repeated strain, and the slow reshaping that follows survival. A skull opened by a blade, a leg removed above the ankle, or a fractured arm pulled back into alignment may carry visible evidence long after skin, bandages. Medicines and memories have decayed. Archaeology cannot recover the pain of the operation, but it can sometimes answer the most important question: did the patient live? Healing bone is not passive. After a fracture or deliberate cut, the body begins rebuilding. New material forms around the damaged area, bridging breaks and smoothing sharp edges. The process continues over weeks, months, and sometimes years. Early healing looks different from long-term remodeling, allowing specialists to estimate whether a person survived briefly or lived for a considerable period. An opening in a skull with sharp, unchanged margins may have been made at death or afterward. An opening with rounded edges, new bone growth, and partial closure shows that the body had time to respond. Trepanation provides some of the clearest evidence. Across Europe, Africa, Asia, and the Americas, skulls carry openings that healed to varying degrees. Some patients survive only long enough for the first signs of repair to appear. Others live for years, their bone gradually smoothing around the margins. In several cases, the same skull contains multiple openings created at different times. The later operation could not have occurred unless the patient had survived the earlier one, transforming the skull into a sequence of medical events rather than a single injury. The concentration of successful trepanations in parts of the ancient Andes is especially striking. Surgeons there appear to improve their methods across centuries. Earlier openings are often larger, rougher, and associated with lower survival. Later examples tend to be smaller and more carefully placed, with stronger evidence of healing. The pattern suggests accumulated experience. Practitioners learn which parts of the skull are safer, how much bone to remove, and which techniques cause less damage. No written surgical manual survives from these communities, but the changing bones function almost like a record of technical refinement. War may explain part of this development. Blunt weapons and sling stones produce depressed skull fractures that can drive bone inward. Trepanation near the injured area may remove fragments or relieve pressure, yet not every operated skull shows obvious trauma, and scholars still debate how many procedures were therapeutic, ritual, or both. Some openings may have been made to treat seizures, headaches, mental disturbance, or symptoms interpreted through spiritual belief. The evidence remains incomplete, but survival is not in doubt wherever substantial healing appears. Amputation leaves an equally dramatic mark. A limb lost through accident can resemble one removed deliberately, making diagnosis difficult. Animal disturbance, erosion, and damage during burial can also separate bones after death. Archaeologists therefore look for cut marks, the position of the removal, and evidence that the surviving bone remodeled afterward. When the end of a bone has healed and reshaped, the individual clearly survived beyond the loss of the limb. One of the most remarkable cases comes from a burial in Borneo, where a young person appears to have survived the deliberate removal of the lower leg thousands of years ago. The remaining bones show long-term healing rather than an untreated traumatic break. The individual lived for years after the procedure, requiring care during recovery and adaptation afterward. The interpretation has attracted attention because the operation occurred in a foraging society far earlier than many researchers once expected complex surgery to exist. The procedure would have demanded knowledge of where to cut without causing uncontrollable bleeding. Major vessels had to be avoided, compressed, tied, or sealed. The wound needed protection through a humid tropical environment where contamination could spread rapidly. The patient then had to survive immobility, fever, hunger, and the difficulty of moving through uneven forest terrain with one lower leg missing. No single explanation fully accounts for the success. But chance alone seems insufficient. Technical skill and sustained care must have played central roles. Other ancient amputees survive with healed stumps, though many examples are later and some remain disputed. Their skeletons may show changes caused by altered movement. One leg bears unusual strain because it carries more weight. The spine curves differently. Joints develop wear from using crutches or shifting posture. These secondary changes reveal that survival did not mean a return to the previous body. The individual learned a new way to move, supported by tools, family members, or the wider community. Fractures are far more common than amputations and provide a broader picture of ancient treatment. Broken bones can heal without medical help, but badly displaced fractures often unite at severe angles or remain shortened. When archaeological remains show a complex fracture healed in relatively good alignment, deliberate reduction and immobilization become plausible. Wooden splints and cloth bindings usually decay, yet the final shape of the bone can preserve their effect. Some individuals survive injuries that would have made independent life almost impossible during a recovery. A fractured femur prevents normal walking and can cause major blood loss. A broken pelvis makes movement agonizing. Multiple rib fractures interfere with breathing and leave the patient vulnerable to lung complications. A person recovering from such trauma needs food, water, warmth, sanitation, and protection. The skeleton records the healed injury. But behind it lies an invisible network of care. Joint injuries produce their own evidence. A dislocation left untreated can create a false joint, deforming the surrounding bone as the body adapts. A joint returned to position may heal with less distortion, though arthritis can develop later. Torn tendons and damaged cartilage usually disappear from the archaeological record, making ancient treatment difficult to reconstruct. Bone tells only part of the story, and many successful procedures involving soft tissue leave no trace at all. Teeth also preserve signs of intervention. Extraction sockets can heal completely if a person survives long enough after a tooth is removed. Some skulls show teeth lost years before death, with the jawbone smoothed over the empty space. Whether each tooth was deliberately pulled or fell out through disease is not always clear. Tool marks, broken roots, and the pattern of loss may suggest extraction, but certainty is rare. Severe dental infections sometimes leave drainage channels through the jaw, showing how dangerous an apparently small problem could become. Evidence for prosthetic devices is rarer because wood, leather, and cloth decay. A carved wooden toe from ancient Egypt is among the better-known examples, carefully shaped and attached in a way that may have assisted walking rather than serving only a decorative burial purpose, where patterns suggest use during life, although scholars continue to examine how functional such devices truly were. Even a modest prosthesis reveals an attempt not merely to save a patient, but to restore part of what had been lost. Cranial injuries sometimes show surgical repair without full trepanation. Depressed fragments may be lifted or removed. Rough edges can be scraped smooth. Fractures may heal around areas that were deliberately cleaned. The distinction between surgery and the original trauma can be difficult to identify, especially when ancient tools leave irregular marks. Modern imaging allows researchers to examine the internal structure of healing without destroying the remains, revealing patterns invisible from the surface. Signs of infection can also remain in bone. Chronic inflammation may create porous surfaces, thickening, or new growth around an injured area. A surgical patient who survives the initial procedure may live with infection for months or years. In other cases, no skeletal response forms because death comes too quickly. Absence of visible infection therefore does not prove a clean recovery. The body may have died before bone had time to react. Archaeological survival rates must be interpreted cautiously. Burial practices favour some populations over others. Elite tombs may preserve individuals who had better access to treatment, while the poor disappear in disturbed or unmarked graves. Dry environments preserve bone differently from wet ones. Successful operations are easier to recognise when healing is extensive, while failed procedures may resemble trauma inflicted at death. The record is not a complete survey of ancient medicine. It is a scattered collection shaped by chance. Even so, what survives overturns the idea that ancient surgery consisted only of fatal experiments. Some patients lived long enough for bone to rebuild around deliberate damage. Some returned to movement after losing limbs. Some endured repeated cranial operations. Others carried healed fractures through decades of later life. Their bodies show that ancient surgeons occasionally did more than postpone death. They created the conditions in which recovery could begin. The skeleton, however, also shifts attention away from the surgeon alone. Healing takes time, and time must be supplied by other people. Someone changed the bandage. Someone brought water. Someone helped the patient relieve themselves, move away from fire, or survive a winter without working. Surgical history is often told through blades and famous medical texts, but bone preserves a quieter truth. The operation may last an hour. Survival occupies the weeks and years that follow. Every healed injury therefore represents two achievements. One belongs to the practitioner who knew where to cut, pull, drain, or bind. The other belongs to the community that refused to abandon the wounded person afterward. In the rounded edge of a trepanned skull, or the remodeled end of an amputated limb, archaeology finds not only evidence of ancient surgery, but evidence of patience, obligation, and care strong enough to keep a damaged body within the world of the living. The healed bones reveal that ancient surgery could succeed, but they rarely reveal who was permitted to receive it. Survival depended not only on the nature of the injury or the skill of the practitioner, but on wealth, rank, location, age, occupation, and the willingness of a community to spend scarce resources on one damaged body. The history of ancient surgery is therefore also a history of inequality. A ruler wounded in battle, a trained soldier, an enslaved labourer. And a farmer injured far from a city may suffer the same broken bone, yet their chances of reaching an experienced healer are radically different. In palace societies, Royal households can support specialists whose services are unavailable to most people. Court physicians receive food, status, protection, and access to imported medicines. They may consult other practitioners, commission refined instruments, and remain with the patient throughout recovery. A ruler can afford prolonged treatment because servants continue the work of the household and state. An ordinary labourer cannot easily stop working for months. Even when the operation is successful, hunger may end the recovery. Military systems create another privileged route to care. A trained soldier represents an investment in equipment, food, discipline, and experience. Empires have practical reasons to repair him if possible. Roman forts establish spaces where wounded soldiers can be housed away from crowded barracks. Surgeons attached to armies repeatedly encounter similar injuries, gaining experience that a village healer may never acquire. Yet military medicine is not equal medicine. Officers may receive faster attention and better quarters. Auxiliary troops, camp workers, captives, and local civilians may receive less. Enslaved people occupy a particularly unstable position. Their owners may pay for treatment when recovery protects economic value, but the decision is rarely controlled by the patient. A skilled household servant or expensive craft worker may be worth saving. An exhausted mine labourer may be replaced more cheaply than treated. Mesopotamian law makes this distinction explicit by assigning different compensation according to social status. The same failed operation that brings physical punishment when performed on a free man may require only financial replacement when the patient is enslaved. The poor often rely on household care, local healers, religious sanctuaries, travelling practitioners, or accumulated family knowledge. These traditions should not automatically be considered inferior. A village bone setter who treats fractures for decades may possess greater practical skill than a literate court physician who rarely handles trauma. A midwife who attends hundreds of births may recognize danger more quickly than a male medical writer whose authority comes from texts. Much ancient expertise exists outside official institutions and therefore leaves little written trace. This creates a major distortion in the surviving record. Medical papyri, legal codes, inscriptions, and formal treatises are produced by literate societies and preserved through unusual accidents. They describe what educated practitioners believe should happen, what rulers want regulated, or what elite patients can access. They do not fully represent surgery in remote settlements, nomadic camps, forest communities, or poor urban neighbourhoods. The majority of ancient operations may have been performed by people whose names and techniques never entered writing. The identity of the surgeon also varies widely. In one society, surgery may belong to a respected physician trained through apprenticeship elsewhere. The same tasks may be divided among bone setters, barbers, priests, midwives, military attendants, executioners, metal workers, or specialists known for one dangerous operation. A practitioner who removes bladder stones may treat little else. A healer skilled in wounds may avoid childbirth. A midwife may perform internal manipulations that formal male physicians rarely witness. The modern category of surgeon can therefore conceal a much more complicated landscape of overlapping skills. Training is often controlled through families or close personal relationships. Knowledge gives status and income, creating reasons to protect it. A healer may teach a son, daughter, nephew, or carefully chosen apprentice while withholding important details from outsiders. Instruments, recipes, and ritual authority can pass together. A family known for treating fractures or eye disease may preserve its reputation across generations. Written manuals widen access in theory. But literacy remains limited, and a text cannot replace the movements learned by watching an experienced hand. Some knowledge may be deliberately secret. A rare drug mixture, a method of locating a bladder stone, or a technique for reconstructing a damaged nose can be economically valuable. Revealing it too freely creates competitors. Ritual traditions may also restrict procedures to initiated practitioners who claim divine or ancestral authority. Secrecy protects status, but it makes knowledge fragile. If a small group dies in war, migration, epidemic, or political collapse, an effective technique can disappear with them. This helps explain why surgical ability does not advance in a smooth line. A procedure known in one place can be forgotten elsewhere. A city may possess skilled eye surgeons while nearby communities rely on crude treatment. Reconstructive methods can flourish for centuries, then vanish from written medicine before being encountered again by foreign observers. Political collapse breaks training networks. Trade disruption removes access to medicines or high-quality metal. Religious or social change alters which bodies may be examined and who is permitted to perform certain operations. Success also varies because the same procedure can conceal enormous differences in technique. Two skull openings may look broadly similar, yet one is scraped slowly by an experienced specialist, while another is cut hastily after a battlefield injury. Two amputations may remove the limb at different heights, under different conditions, with different control of bleeding. Archaeology may group them together, but the patients did not face the same operation. Selection of patients may make skilled practitioners appear more successful. A cautious surgeon refuses those already too weak, too infected, or too badly injured to survive. A reckless operator accepts every case and produces more deaths. Ancient medical texts sometimes distinguish treatable conditions from those that should not be touched, suggesting that prognosis protects the healer as well as the patient. Knowing when not to operate can raise survival rates without improving the technique itself. Age and general health matter greatly. A young, well-fed patient may survive blood loss and infection that kill an older or malnourished person. Chronic disease weakens recovery. So do parasites, repeated hunger, dehydration, and earlier injuries. Ancient surgeons cannot measure blood pressure or test organ function, but they observe skin color, strength, consciousness, appetite, breathing, and the quality of the pulse. Their judgment may be crude, yet it influences who is offered the knife. The environment surrounding the operation can be as decisive as the surgeon's hand. A procedure performed in a orderly room with clean cloth, fresh water, and several assistants differs from one performed in mud after battle. A patient recovering in a wealthy household receives food, warmth, and repeated dressing changes. Another lies among dozens of wounded people sharing insects, bedding, and contaminated tools. The same surgical knowledge produces different outcomes because the conditions of recovery are unequal. Reputation complicates the picture further. Successful healers attract difficult cases, which can lower their apparent success if they treat patients others have rejected. Charismatic practitioners may gain fame through a few dramatic recoveries, while their failures disappear from memory. Families remember the patient saved after a terrible wound. Those who die may be blamed on fate, divine judgment, or the severity of the illness, without systematic records. It is almost impossible to separate genuine expertise from selective storytelling. Scholars still debate how professional many ancient surgeons truly were. A collection of specialized instruments suggests repeated practice, but a toolkit may belong to a general healer rather than a dedicated operator. A medical title may indicate prestige without revealing actual skill. A detailed written procedure may preserve an ideal that few practitioners could perform. Conversely, communities without texts may possess highly effective techniques that archaeology can only glimpse through healed bone. The mystery is not whether ancient surgery existed. The scars or instruments and manuals make that undeniable. The deeper mystery lies in its distribution. How many people ever reached the best practitioners? How often were dangerous operations attempted? How much knowledge remained local and unwritten? How many successful traditions disappeared without leaving enough evidence to be recognized? What survives suggests a world filled with small islands of expertise. One community masters cranial surgery. Another becomes known for repairing noses. A military camp develops efficient methods for removing projectiles. A family of healers preserves the ability to cut bladder stones. Between these islands stretch enormous regions where treatment is simpler, improvised, or unavailable. Ancient surgery is therefore neither universally primitive nor uniformly advanced. It is uneven, personal, and vulnerable. Its success depends on a chain that can break at any point. The patient must reach the healer. The healer must possess the right knowledge. The tools must be suitable. The operation must be timed correctly, and the community must sustain recovery. When all of these conditions align, the result can seem astonishingly modern. When even one fails, the ancient limits return with brutal speed. The knowledge carried by these scattered islands of expertise does not remain fixed within the ancient world. It travels with merchants, soldiers, captives, pilgrims, physicians, translators, and displaced communities. A surgical method developed in one language may survive in another long after the original school has disappeared. An instrument changes shape as it crosses a frontier. A treatment loses its ritual explanation but keeps its practical steps. Another technique is copied incorrectly, reduced to a few lines, and gradually abandoned. The survival of ancient surgery depends not only on whether an operation works, but on whether someone considers it worth remembering. The great medical traditions of Egypt, Mesopotamia, India, Greece, Rome, and many societies without surviving texts never exist in complete isolation. Trade routes carry medicinal plants, metals, resins, spices, and drugs across continents. Armies bring foreign wounds and foreign healers into the same camps. Cities attract practitioners from distant regions. Patients travel to temples, courts, and specialists whose reputations extend beyond local boundaries. Knowledge moves unevenly through these networks, sometimes openly and sometimes hidden inside family traditions. Greek medical writing becomes particularly influential because it is collected, copied, debated, and later translated across a vast area. The works associated with Hippocrates preserve detailed approaches to fractures, joints, wounds, and prognosis. Hellenistic anatomical research adds new observations about nerves, organs, vessels, and the brain. Roman-era writers such as Celsus describe operations and instruments in Latin, while Greek-speaking physicians continue to dominate much-learned medicine within the empire. Among them, Galen becomes one of the most influential medical authorities in history. Working during the 2nd century CE, he treats gladiators, studies wounds, performs animal dissections, and writes extensively about anatomy, physiology, drugs, and treatment. His experience with injured fighters provides unusual access to living anatomy. Deep wounds expose muscles, tendons, bones, and organs that formal human dissection might not reveal. Gladiators are valuable performers, so their survival matters economically, giving Galen strong reasons to improve wound management. His writings contain important observations but also serious errors. Because much of his anatomical knowledge comes from animals, he sometimes describes structures that do not exist in humans or misunderstands how human organs function. Later generations treat his authority with such respect that mistakes become difficult to challenge. This is one of the central contradictions in the legacy of ancient medicine. Preservation saves valuable knowledge. But excessive reverence can preserve error just as effectively. As the Western Roman Empire weakens, political fragmentation disrupts institutions that supported medical training and textual copying. This does not cause surgery to vanish overnight. Local practitioners continue setting fractures, draining abscesses, extracting teeth, treating wounds, and amputating destroyed limbs. Monasteries, households, military groups, towns, and travelling healers preserve fragments of older knowledge. Yet access to large libraries and formal education becomes uneven. Some Greek texts become rare or disappear in Western Europe while continuing to circulate elsewhere. In the Eastern Roman or Byzantine world, medical compilations preserve much Greek and Roman learning. Physicians collect earlier writings, summarize procedures, and add observations of their own. These compilations matter because many original works are eventually lost. A passage copied into a later handbook may become the only surviving trace of a much older surgical tradition. The copy is never neutral. Authors select, shorten, reorganize, and interpret, shaping what later generations believe the ancient world knew. A major phase of preservation and expansion occurs in the Islamic world. Beginning in the early medieval centuries as scholars translate Greek, Syriac, Persian, and Indian medical works into Arabic. Translation centers connect knowledge from regions that had previously been separated by language. Physicians do not simply store ancient texts. They criticize them, compare them with experience, develop pharmacology, describe instruments, and create new medical syntheses. One of the most important surgical writers is Al-Zahrawi, known in Latin Europe as Albucasis. Working in Al-Andalus around the 10th and early 11th centuries, he compiles an extensive medical encyclopedia whose surgical section includes descriptions and illustrations of numerous instruments. He discusses cautery, wound treatment, fractures, dental procedures, bladder stones, childbirth complications, and the removal of foreign objects. His writing reflects earlier traditions. But it also includes practical experience and a clear concern with the training and conduct of the surgeon. Al-Zarawi's instruments reveal continuity with the ancient world: hooks, forceps, probes, scalpels, cautery tools, and specula retain familiar purposes. Yet their presentation in an organized illustrated text makes them easier to reproduce and teach. His work is later translated into Latin and influences European surgery for centuries. Ancient knowledge has now traveled through several languages and political worlds, altered but still recognizable. Indian surgical traditions also continue through copying, commentary, and practice, although their history is complex. The Sushruta tradition survives in manuscripts whose contents reflect layers of revision. Techniques such as nasal reconstruction persist in parts of South Asia through practitioner communities even when they are unfamiliar elsewhere. When European observers later encounter Indian reconstructive surgery, they describe methods that appear startlingly advanced to audiences who assume such knowledge must be modern. This encounter illustrates how medical history can be distorted by loss. A technique may seem newly invented simply because one society has forgotten it, or never preserved it in widely read texts. The operation itself may have continued quietly in another region for generations. Rediscovery is often not the recovery of something dead, but the recognition of knowledge that survived outside the institutions writing the dominant history. In medieval Europe, surgery gradually becomes associated with a range of practitioners. University-trained physicians often focus on diagnosis, internal disease, diet, and medical theory. Manual operations may be performed by surgeons, barber surgeons, military specialists, bone setters, lithotomists, and itinerant operators. The boundary is never absolute. Some learned physicians perform procedures, and some practical surgeons become highly educated still. The separation between intellectual medicine and manual surgery can weaken communication between anatomical theory and operative experience. Barber surgeons cut hair, shave faces, pull teeth, lance abscesses, treat wounds, and perform bloodletting. Some become highly skilled in battlefield care and amputation. Others possess only limited training. Traveling specialists advertise cures for cataracts, hernias, or bladder stones, moving quickly between towns. A successful operator can gain fame. An unsuccessful one can leave before the patient dies from infection. Ancient procedures continue because the same human problems continue. Bones break in familiar ways, teeth rot, stones obstruct the bladder, cataracts cloud the lens, weapons lodge in tissue, childbirth becomes obstructed. Without anesthesia, antisepsis, and reliable control of blood loss, surgeons remain trapped by the same limits faced thousands of years earlier. Instruments improve, anatomical knowledge expands, and texts become more detailed, but major internal surgery is still usually fatal. The Renaissance brings renewed access to Greek medical works and a growing willingness to examine the human body directly. Anatomists challenge inherited errors through dissection. Andreas Vesalius demonstrates that several long-accepted descriptions based on animal anatomy do not match human bodies. Printed books spread corrected illustrations more widely than handwritten manuscripts could. Surgeons gain better maps, though a map alone cannot make the journey safe. Battlefield experience continues to drive innovation. Ambroise Paré, working in the 16th century, questions the use of boiling oil for gunshot wounds and promotes gentler dressings. He develops techniques for ligating blood vessels during amputation rather than relying entirely on cautery. These changes reduce suffering and sometimes improve survival. But infection remains uncontrolled, and ligatures themselves can carry contamination deep into wounds. Only in the 19th century do several barriers begin to fall in rapid succession. Reliable anesthesia allows surgeons to operate more slowly and deeply without the patient fighting every movement. Germ theory reveals that infection is caused by living organisms rather than bad air or spontaneous corruption. Antiseptic and later aseptic methods transform the operating environment, instruments, hands, dressings, and rooms are cleaned according to principles ancient practitioners could never fully understand. Blood typing, transfusion, imaging, antibiotics, and modern monitoring push surgery into regions of the body once considered unreachable. These advances can make ancient operations look crude, yet modern surgery retains many of their foundations. Wounds are still cleaned, drained, closed, or deliberately left open according to contamination. Fractures are aligned and immobilized. Dead tissue is removed. Pressure controls bleeding. Ligatures close vessels. Flaps of living skin reconstruct damaged faces. Catheters drain blocked passages. Scalpels, forceps, probes, retractors, needles. And saws remain recognizable descendants of instruments used centuries or millennia earlier. The difference lies in accumulated systems. The modern surgeon does not work safely because the hand is fundamentally steadier than that of an ancient specialist. Safety comes from anesthesia, sterile technique, trained teams, laboratories, blood supplies, imaging, intensive care, regulated education, and the ability to treat complications after the operation. Ancient surgeons possessed pieces of this larger structure, but never the entire network. Their legacy is therefore not a straight road leading inevitably to the present. It is a landscape of discoveries, mistakes, interruptions, and recoveries. Some ancient techniques were effective for reasons their creators could not explain. Others survived because of authority despite causing harm. Knowledge moved between cultures, disappeared from one region, and continued in another. The evidence remains incomplete. And many of the people who shaped surgical practice remain permanently anonymous. Yet their presence is still felt whenever a wound is examined before it is cut, whenever a surgeon chooses the correct instrument, whenever damaged tissue is removed while healthy tissue is preserved, and whenever restraint is valued as highly as intervention. The first surgeons could not see bacteria, measure blood pressure, or silence pain reliably. They worked with incomplete maps in conditions that turned every incision into a gamble. Their greatest discovery was not any single operation. It was the realization that the human body, although vulnerable, could sometimes survive deliberate injury when knowledge, precision, and care were placed between the patient and death. The oldest surgical wounds now rest quietly in museums, laboratories, and graves beneath landscapes that have changed beyond recognition. The firelight is gone. The stone scraper has fallen from the hand that once held it. The names spoken around the patient have vanished with the language, leaving only a circle in bone, a shortened limb, or a fracture joined carefully enough to carry someone through the remaining years of life. Those traces do not describe a world free from fear. Ancient surgery is filled with suffering, failure, inequality, and loss. Many patients die beneath the blade or in the fevered days that follow. Many never reach a healer at all. Yet among the remains are bodies that refuse the simplest story. They show wounds that close, bones that rebuild, and lives that continue after injuries once assumed to be unsurvivable. Across thousands of years, the instruments change more slowly than the world around them. A sharp edge opens the skin. A probe searches the darkness beneath it. A thread draws separated flesh together. Another pair of hands brings water, replaces a dressing, and keeps watch while the patient sleeps. Surgery has always depended on that combination of intervention and care, on the brief violence of the operation and the long patience of recovery. Modern operating rooms seem infinitely distant from the prehistoric shelter or ancient military fort. They are bright, measured, controlled, and filled with machines capable of detecting the smallest change. Yet beneath the technology remains the same fragile body and the same ancient decision whether opening it may offer a better chance than leaving it untouched. The people who made that decision first could not know where their experiments would lead. They knew only the wound before them, the tools they possessed, and the uncertain strength of the person waiting beneath their hands. Their knowledge passed through memory, metal, manuscript, and scar, surviving wars, collapsing empires, forgotten languages, and centuries of silence. And now, in the smooth edge of an ancient skull, time preserves a final quiet image. Bone has grown around the place where death once entered. The opening remains, but so does the healing, holding within it the memory of a patient who endured, a healer who dared, and a community that waited long enough for life to continue.